You are live now.
Very good evening to one and all of you for our very vibrant webinar, Enhancing Concepts in OCT and OCT Angiography Markers in Retina. We are truly lucky, as you can see, we have an expert panel, the top experts and absolutely distinguished speakers to enhance the concepts on this topic. We have with us Dr. Raj Narayan, who's to be joining us anytime now, who's the Director and Network Head, Clinical Research, and also heading Operations and Systems at the LV Prasad Eye Institute, Hyderabad, and consultant Retina, a very dynamic, prolific surgeon to pave the way. Dr. Lalit Verma is unable to join us. We have with us Dr. Unni Krishnan Nair, Medical Director and Senior Consultant, Vitreoretinal Services, UVA, Neurophthal and Electrodiagnostics, and what more, Doctor, of the Chaitanya Group of Hospitals to guide us. We have with us Dr. Anand Rajendran, who's the Chief of Vitreoretinal Services from Aravind Eye Care Systems, Chennai, has held honorary posts at VRSI and with great accolades to his name. We have with us Dr. N.S. Murlidhar, President of the Retina Institute of Karnataka, one of the most leading retinal specialists of our country with great eminence. We have with us Dr. Giridhar, who is to join us soon, who is the Medical Director and Chief Mentor of the Giridhar Eye Institute, an institute which he carved and evolved to a peak of success, a dynamic surgeon of great repute. We have with us our dear Dr. Malika Goel, the Senior Consultant and heads the Retina, Vitreous and Uveitis Services at Apollo Eye Hospital, Hyderabad, who has held honorary posts in AIOS, a very dynamic personality to reckon at all times. And moderating with me is Dr. Srinivas Joshi, who leads his Joshi Eye Hospital, a brilliant vitreoretina surgeon, member ARC South, the future of our country. Aren't you, Srinivas? We shall now go on to our first speaker in this session, Dr. Niroj Kumar Sahu, who's a clinical faculty, Retina and Vitreous at LV Prasad Eye Institute, talk on central bouquet abnormalities and EIFL. On to you.
Good evening, everyone. So at the outset, I'd like to thank Dr. Chitra and AIOS for giving me this opportunity. So I was asked to speak about the central bouquet abnormalities and EIFL. So I'll be dividing the talk into three aspects, what's, how's, and why's of this entity. So let us come to the first objective. What is the central foveal bouquet? So it was first known as the Rochon-Duvinol bouquet of central cones, which was less than 100 microns in diameter and consisted of around 2,000 of the thinnest cone photoreceptors. However, it was later on by Yamada and Gas who described the presence of a Muller cell cone, which is nothing but a plug of tissue at the center of the foveal cone. So thus we can describe the central bouquet as a dense array of cone photoreceptors along with Muller cells in the central foveal region. So what abnormalities can this structure have? The CB abnormalities can be divided into three categories. First is the presence of a cotton ball sign. Second, presence of a foveolar detachment. And third, an acquired vitelliform lesion. So let us go one by one for each one of them. First one is a cotton ball sign. So it is a thick, roundish, fuzzy, hyperreflective area that is present between the inner segment of ellipsoid zone and the interdigitating zone, as we can see here in the yellow circle. And it is due to the misalignment of the photoreceptors that causes differential reflectivity that gives rise to this kind of a picture. Next is the foveolar detachment. As the name indicates, it is again when the traction increases, it exceeds the addition between the photoreceptors and RPE that results in detachment of the cones from the RPE, resulting in a small neurosensory detachment. Next comes the acquired vitelliform lesion. These are dome-shaped hyperreflective material in the subretinal space that extends from the ellipsoid zone to the RPE. And again, it is due to the chronic separation of the cone from the RPE. So when the debris gets accumulated and overcomes the physiological capacity of the RPE to pump it back, it results in accumulation, and this material can result in disruption of the morphology and physiology of RP photoreceptor complex. This vitelliform lesion again can migrate upwards into the inner retina, and along with of small ellipsoid zone defect. This can again decrease vision in some patients. So how are they formed? Two models have been described by Bouquet et al. So the first one involves the parafoveal molar cells, as we can see here. These are Z-shaped cells with the attachment to the cones being vertical. So when there is traction from the ERM, it results in pull of this vertical part of this Z-shaped molar cells, resulting in the traction being transmitted to the central bouquet. The next model here was that according to this model, these eyes may or may not have vertical arrangement of molar cells in the inner retinal layers at the center of the fovea. And these vertically arranged molar cells, you can see here, this can directly transmit the traction force by the ERM to the central foveal bouquet. So the sequence of progression of the central bouquet abnormalities can be visualized through these diagrams. The molar cells having no traction on the cones, resulting in no distortion of the central bouquet. When the traction increases, it initially forms the cotton ball sign, which again increases to form the foveolar detachment, followed by the vitelliform deposits. And sometimes the deposits may migrate into the inner retinal layers, along with some amount of disruption of ellipsoid and ELM. This brings us to the second objective. What is ectopic inner foveal layers? So before going into the description of this entity, we need to understand the newer OCT-based classification of ERM, which was again proposed by Bouquet et al. In 2017. The first stage is the stage of mild ERM with negligible or no morphological or anatomical distortion of the central fovea. You can see only the ERM is present, no abnormalities at the center of the fovea. The second stage, where the ERM progresses and there is progressive retinal distortion, resulting in the foveal depression being lost. We can also see here that the outer nuclear layer is stretched and wide. But it is the stage 3 that has been described to have the ERM along with the continuous ectopic inner foveal layers. So what exactly is the ectopic inner foveal layers, or EIFL? So this is presence of a continuous hypo or hyperreflective band that extends from INL and IPL across the fovea, and this can be seen in all OCT scans centered around the fovea. Why hypo and hyper? Because you can see here the INL is continuous here, and it can be seen as a hypo, and the IPL also can be seen. The continuation of this can be seen as a hyper band at the central thickened EIFL. Again, the stage 4 has the presence of ectopic inner foveal layers along with distortion and thickening of the anatomical structures at the inner macula. So, these stages represent a continuous evolution of the process of ERM formation. And this can be illustrated in another example here, where this patient presented to us with a vision of 20/30. And we can see here a presence of a stage 3 ERM. We can see ectopic inner foveal layer along with a wide outer nuclear layer. And this patient was actually observed initially for 2 years. The patient came back with a distortion of the inner foveal layers with a drop in visual acuity. This we classified as, again, a stage 4 ERM. So why is it important to clinically know about these entities? ERM stages and the central foveal bouquet abnormalities tend to have some correlation. It was seen by Bouquet et al. Again that the CB abnormalities have the highest frequency in stage 2 ERM.
So 1 minute remaining.
In stage 3 ERM and 4 ERM, because of the EIFL, there is usually less amount of CB abnormalities. So is EIFL protective for CB abnormalities? Again, it was described with the help of this model of spring and masses, where described that due to the EIFL, that force transmitted by the Muller cells by the ERM gets decreased when it reaches the central foveal bouquet and resulting in less of abnormalities. Again, correlation of visual acuity. Patients with cotton ball sign, that is earlier stages of CB abnormalities, do better, have a better visual acuity, while the foveal detachment and the vertiform lesion group have a worse visual acuity. Again, eyes with higher central foveal thickness and EIFL and stage 3 and stage 4 all three have lesser visual acuity. Even in terms of surgical outcome, it has been seen that patients who have a stage 2 EIFL, they do better structurally. As you can see from this graph, that at the end of 12 months, almost 71% of eyes develop stage 1. And whereas in stage 3 and stage 4, the majority of eyes remained in stage 3 ERM. Even for functional outcome, a patient with stage 2 did much better than stage 3 and stage 4. So, but there was one more study by Brinkman et al. Where they found actually that the ERM stage and the CB abnormality actually did not correlate with the visual acuity, and the p-value, as you can see here, is not significant. However, we can see some amount of benefit if we do surgery early. The mean visual gain was slightly better in eyes who had a lower stage and lower stage of CB before surgery. So I'll just like to end with these two case scenarios. These were two cases where we had two stage 2 ERM which were operated and resulted in a very good anatomical and functional outcome in both the patients. Whereas in another case where there was a stage 3 ERM, it was operated, although there was some amount of restoration of the inner foveal structures, the visual acuity did not improve to the extent that the other two cases did. So take-home messages from my presentation: presence of high grades of CB abnormalities can correlate with a worse visual function. Presence of EIFL can be protective against formation of CB abnormalities, and early stages of ERM may have better structural and functional outcomes after surgery. Thank you.
That was a wonderfully crisp talk, Dr. Niroj. Thank you very much. Dr. Srinivas?
Yes, madam. Thank you, Niroj. That was really a wonderful question. I have my question. Dr. Raja is here.
He said Dr.
Unni and Dr. Anand Rajendran can. Sir, we all know that stage 3, stage 4 are having the worst visual prognosis. So it has been a better counseling tool nowadays for the patients when we do the ERM surgery and show them these OCT findings. Other than that, we also have the pseudo hole formation when the CMT increases more than 400, where there is a EZ disruption. All these are considered as the prognostic factors. So how best can we utilize this as a counseling tool for our patient as a prognostic factor?
So thank you, Srinivas, and thank you, ma'am, for the invitation. I'll just start by taking this one. Thank you. So what is very interesting here is that this is one of the first biomarkers which give us the point of intervention and why. So it's very, very significant. The CB abnormality development, there is a point in which you have the cotton ball opacity and the point of foveal detachment. One particular point is that there is some reversal of the CB abnormality when the traction is relieved at this point, which means the development of the foveal detachment has been thought to be a reversible sign. After that, which the vitelliform is not a reversible sign. Vitelliform is more associated naturally with RP abnormalities. That is one point. The second point is IFL. We're talking about not only visual recovery after ERM surgery, we're talking about structural recovery. So the structural recovery and the better foveal contour after an ERM surgery is better before the IFL forms. So you put 2 and 2 together. For the first time in our clinical experience now, we have two tools that tell us when to operate. It is not bad to operate early. You don't look at 6.6 or 6.9 or 6.12 like we used to. Okay, we don't operate this ERM because it is 6.9. No. When you find these features, you know there is a natural progression into a stage of irreversibility. And that is what these two biomarkers tell you. That is, at what point of time there is surgical irreversibility. That is, after surgery, the OCT findings do not recover to the previous features. So that is the most key point about these two biomarkers.
Wonderful. Very rightly said. Anand sir, a quick question. Is there any other prognostic factors you look into it apart from the CBs and the IFL when we are treating with the ERM surgeries?
Yeah. So, I mean, one is, as Uni mentioned, that, these are factors that we, intuitively believe may be reversible. But what the science shows us is that, especially with IFL, though it's seen in stage 3 and stage 4, ERMs, once it is onset, you will never ever reach the point of satisfaction for that patient by doing a surgery. So that is one thing. And of course, I do believe that visual acuity is also important from a patient's perspective. So that for me still is part of the criteria. The third thing I would like to add on to say is look at schisis, skytic membranes, anything which is leading on to so much of schisis, as you showed in, I think, your stage 3, one here, that is onset. That for me is again a poor prognostic. There will also be many other markers. There's EZ disruptions, there's ORDs. We are going to talk about LHEP. I won't want to jump the gun here. This whole program is going to talk about all that, and we're going to be, I could talk on for 10 minutes on that. I will stop short of saying that a lot of these structural markers which are going to follow, in fact, at the next talk, we're going to talk about LHEP and ERM and other stuff like that. So all these structural factors, as opposed to a pristine macula with a thin ERM sitting on top like a cap, those are all going to, in some ways, show us, poor prognostic markers. So all those, for those reasons.
Thank you, sir. Thank you.
We shall now go on to our next speaker, Dr. Vinod Agarwal, Assistant Professor, VR Services at RP Center, New Delhi. And he is going to talk on another interesting topic, lamellar hole, epiretinal for epiretinal proliferation and omega sign. On to you, doctor.
Thank you, ma'am, for nice introduction and kind words. Dr. Srinivas, can I make a small comment about the previous?
Yeah, that's what I was able to tell you. So once you finish your presentation, you can take both the things together.
No, I will forget then.
Okay. Go ahead.
So basically, a very nice talk, Dr. Sahu. So one thing you talked about that how ectopic inner foveal layers are protective against the central bouquet abnormalities. Now one has to understand here very clearly that while in ectopic inner foveal layers, the basic abnormality is that there is centripetal contraction. So there is force towards the center of the fovea. While in the central bouquet abnormalities, the traction is in the anterior-posterior direction or the centrifugal force. So that is why once one kind of force is happening, the other kind of abnormalities wouldn't occur. So that is what my understanding is there on the topic. So I guess the same thing has been said in the literature, but more in a complicated way.
So on to you, Dr.
I'll start my talk. I try to keep it very simple because I know by the end of it, the things in OCT really becomes complicated at times. So I'll be talking about lamellar hole associated epiretinal proliferation. Now, this is a clinical entity which is seen only on OCT. When I say only on OCT, I want to differentiate here it from the conventional epiretinal membranes, which are seen clinically as well. Now, what is LHEP? Basically, it is nothing, but it is a material of homogeneous medium reflectivity, which is located on the epiretinal surface, and it usually surrounds the lamellar macular holes. Now, one thing, it has been very clearly shown in literature that in the absence of defect of the inner retina, this LHEP is usually not seen. Now, as compared to the conventional ERMs, the LHEP or this particular entry is non-contractile. So when we say non-contractile, that means there will be no edema, retinal edema and cyst, though at times you can see degenerative cysts inside the edges of the lamellar hole. Now, usually they are at the surface of the retina, but at times they go and are in continuation with the middle layers of the retina. And sometimes they will even go and fill the base of the hole. And they, in the initial description by Pang et al., the authors hypothesized that these are basically due to, LHP is basically due to proliferation of the middle retinal layers or Muller cells. And they found that though they labeled it a lamellar macular hole associated proliferation and found it in 30% of the cases of lamellar hole, they reported it simultaneously in cases with full thickness macular holes as well. Now, just to mention here and not to discredit any of the previous authors which have identified it, we must remember that while Pang et al. Were the first to characterize it lucidly, many other authors have described it before. The first description was in Ophthalmology in 2006, where the author described that many of the ERMs in their patients of lamellar macular holes were unusually thick on ultra high resolution OCT. Later on, Michael Kowalska et al. Noted that these dense non-contractile membranes were present in their series as well, and they were similar to the thick membranes noted by the previous authors. And later on, another set of authors reported that these thicker, denser ERMs do not have any temporal relationship with the normal ERMs, and they suggested that these two type of ERMs, that is LHP, which is called now, and the normal ERMs tend to have a different pathogenesis. Now, as I mentioned before, these are mainly present on the surface of the retina, but at times, as you can see, they go into the edges of the hole and they are continuous with the middle layers of the retina. At times, they even go on to fill the base of the hole, and they look like they make the whole architecture look like a normal foveal contour. But remember, this is all homogeneous material, which is LHP, and actually the whole retinal tissue is very thinned out. Now, just to give you an example how they look different from the normal ERM, this is how a normal ERM would look like, but there's no homogeneous tissue between the retina and the ERM. Now, as I mentioned, they were earlier described in association with lamellar holes, but of late they have been described in a variety of conditions, including FEVR, PVEC, even associated with normal ERMs. Sadda et al. Recently reported that they can be seen in other variety of conditions, including ARMD, diabetic retinopathy, venous occlusions. And one very important condition they noted that the patients who have history of macular peeling also showed some amount of LHP. This shows that LHP may actually be a reparative response to the macular damage. Now, what are the implications of this term, that is LHP? Now, a recent study noted that eyes with lamellar macular hole and LHP tend to have poorer visual acuity. They have larger lamellar macular hole diameters. They tend to have thinner retinal thicknesses inside the hole, and they have higher incidence of ellipsoid disruptions. And this is when they compared their eyes with lamellar macular holes with LHP to the eyes without LHP. Now, what happens to LHP over a period of time? Some authors have shown that area of LHP does increase with time, and this is associated with enlargement of the hole and area of EZ loss. But clinically, it may not be very significant. And most of these studies have shown that lamellar macular holes with or without LHP tend to remain stable over large periods of time. Now, to sum it up, the clinical significance of LHP is that even in lamellar macular holes, where there is no LHP, there is doubtful role of the surgery. While many eyes improve, up to 20% of the eyes with LMH without LHP may go on to lose some amount of vision. So when I say that, the eyes with lamellar macular hole and LHP actually tend to do much worse. And the consensus is that whenever we treat patients with lamellar macular hole and LHP, we do not have to peel off the LHP completely. And whenever we operate them, we must add ILM peeling or inverted flap. This was my first part of the talk. Second part is something called omega sign. which was described by us only from RP Center. This is about a condition called combined hematoma of retina and retinal pigment epithelium, which is nothing but a rare solitary unilateral and benign lesion. It is usually present in young patients who present with decrease of vision, and it tends to have three components. One is the epiretinal component, vascular component, and an intraretinal or RPE component. Now, in a particular patients, either of these components can be predominant, and they can be in varying proportions. And Gass in their original paper described that these combined hematomas can be of two varieties, one which occupy the disc and the one which involve the macula primarily. Now, macular CHRPs, it's not an uncommon lesion.
1 minute remaining, sir.
Yeah, especially in a practice like ours, we get a lot of referred cases. So ERM is a very frequent differentiate, and FFA is not a good tool to differentiate ERM from combined hematoma because FA is not able to assess the intraretinal component. OCT may be useful as many signs like Maxi and mini peaks have been described, as you can see here, but they may not be there in all the cases, and these peaks can be present in patients with ERM. Now, ERM peeling has become a common procedure, especially in MIVS era. So many people tend to operate these patients, but results may be poor because at times epiretinal component is integrated with the intraretinal component in these combined hematomas. So we described this particular sign with which we can distinguish combined hematomas from ERMs. So as you can see, this is a patient with macular CHRRP, and when you do the OCT of these patients, we can see this omega shaped alignment of the inner retinal layers, which is bounded by the outer plexiform layer. So we saw this in a variety of patients, and we described this particular condition. As you can see, most of these patients would have omega shaped infiltration of the inner retina. But of late, we have realized that a similar situation can sometimes be seen in secondary ERMs, which can behave like CHR combined hematomas. So this is a patient who has undergone a buckling surgery, had a secondary ERM, and is showing something which looks like a combined hematoma. So to conclude, LHAP basically signifies degenerative lamellar macular hole and a relatively poor prognosis. Omega sign indicates towards the diagnosis of combined hematoma, and whenever we take on peeling in these particular patients, we should be very careful. And subtle clinical signs like these can help us in better decision making in our day-to-day practice. Thank you very much.
Oh, that was a wonderful talk again. I'm going to ask a very simple question before Srinivas takes on. What is the significance of this glutamine synthetase enzyme in the histopathology of LHEP? What does it?
I think a lot of histopathological studies have been done, but I am not aware of this particular enzyme. Dr. Srinivas?
No, not me. I am also not aware of this.
I think glutamine synthetase is something that identifies myofibrils and myocytes. So it can differentiate between the contractility part. So when ERMs are removed, that is where the first diagnosis of this non-contractile element sitting on top of the retina came into being. So any myocyte or myofibrillin can be detected by the enzyme. So that is when the fact that the LHEP could be a consequence of a degenerative process and not the process that starts the tractional element came into concept here. The presence of the absence of fibrillary or myofibrillary elements.
Thank you.
Okay, I have a question.
But one thing I just wanted to ask Uni sir. We all know that ERM contains more of myofibroblasts and LHEP contains the glial cells, hyalocytes and the fibroblasts. And though it has been described that the LHEP doesn't have that much of contractile property as compared to the ERM, am I right?
Yes.
Yes.
So, Dr. Vinod, my question is, when we do this ERM peeling and ILM peeling, I think they have described it as EPMH, epiretinal proliferation associated with macular hole. And when it's a large hole, when we want to do an inverse peeling. So most of the time, along with this epiretinal proliferation, we all know that the ILM sticks to it and it comes off. Although the authors say that you have to first remove the epiretinal proliferation and then do the ILM peeling. So how will you manage in these cases? Will you stuff the epiretinal proliferation also if it's the whole size is more than 800 or 1000 microns in diameter?
You're talking about full thickness macular holes or lamellar?
Yes, full thickness macular hole. Full thickness macular hole.
See, one thing is again very clear in the literature that whenever you have epiretinal proliferation in association with full thickness macular holes, even if you are able to close the macular holes, when I say close, type 1 macular hole, the outer layers, that is EZ and ELM, do not tend to close, and the visual results are relatively poor. So second question, coming back to your question, when you talk about peeling, so we really don't know. All you can do is once you have peeled the epiretinal tissue, and again, as I said, you do not want to peel it completely off the macular hole. You would like to be, you will like that this is sticking to the edge of the hole when you have peeled. Once you have peeled the epiretinal component, you can stain again, and you can see if ILM is there, you can peel off, and at least you can peel off the ILM up to the arcade, so that even if you are not sure about the central part, you have removed the traction from the outer part of the macula.
Right.
Yeah, I'd just like to add one quick comment, one observation that, this LHEP, as the name suggests, this is more often commonly seen with lamellar holes than macular holes. So the entire pathogenic process is very different. It's like alluding to what he was saying, this traction component and this, degenerative component. So one should not, put it in that universal macular hole. We see macular holes far more often, than lamellar holes. And I think the incidence of LHEP is about 3 times as much in lamellar holes than in macular holes. It's also been reported in vitreomacular traction, where there is no breach. So there is a completely different pathogenic underlying process. I think we should keep that in mind. The rest of the points, I think, Vinod is already mentioned.
I think you've said it very correctly. The incidence is much more in LHEP, but lamellar holes, but it is seen in up to 10% of the full thickness macular holes. In fact, one of the study has shown that whenever you get a macular hole, full thickness macular hole in the setting of retinitis pigmentosa, they are almost always associated with the LHEP as well. So we really don't know as of now if LHEP is a good enough terminology.
Thank you, doctors, for the discussion. We shall now go on to our next speaker, Dr. Srinivas Joshi, who's going to talk on swelling of the arcuate retinal nerve fibers, dissociated nerve fibers, and outer retinal defects in the macular hole surgery. So lots to tell in 8 minutes. On to you, Dr. Srinivas.
Yes, madam. Just a second. Just trying to share my screen. Yeah. Good evening, everyone. Once again, welcome to the ARC webinar. So today I'll be speaking on Dawnfield and Dawnfield. Thank you, Chitra ma'am, for having included me. The talk in this prestigious speakers are there. So as we all know, we have 2 kinds of membranes where we need to do the ILM peeling. The one is where we have the macular hole, and the second one where we have is the epiretinal membrane. So coming to just a little bit of brief discussion, the ILM transmit the forces from the vitreous to the retina and hence contributes to the biomechanical strength. So thus ILM removal reduces the strength almost by the half. So is there any other procedure? As any other procedure, ILMP causes some changes in the post-operative period. It is called, when it is early, the authors have named it as Dawnfield, and when it appears late, then it is called as Dawnfield. So when we look into the Dawnfield, that is nothing but the swelling of the arcuate nerve fiber layer after the internal limiting membrane peeling. It's basically because many hypotheses have been said that it's because of the direct surgical trauma and causing disruption of the exoplasmic flow, and ILM peeling itself it causes a disruption of the end plates of the Muller cells, and it usually disappears by 3 months because it's a transient feature after the surgery, and usually it does not affect the visual recovery. And if you look into this another paper by Rossio, who has said that intraoperative grasp site correlation with morphological changes in the RNFL after ILM, they observed that the hyporeflective arcuate striations were followed grasp site up to the optic nerve head. So when we look into the hyporeflective and hyperreflectivity on the OCT, if you can see here, this is what I was mentioning about is the arcuate kind of the striae, that is the hyporeflective striae. And when we look into the OCT, we see the inner retinal hyperreflectivity. That is what is described as Sanfil because of the acute, that is after ILM peeling, when we see it post 10 days to within 2 months, they have described it. And again, if you see over 6 months, if you can see here, comparing the two, the hyperreflective, that is the dark striae, has almost disappeared, and the inner retinal hyperreflectivity is also come down drastically. And most of it have mentioned that it is still asymptomatic, and it just shows the changes in the retinal morphology. Now, when we come to our own case, where we see here, this is the case where we had a full thickness macular hole, and you can see the inner retinal MLD, and the basal diameter was around 1287 micron. The patient had a good type 1 closure, and if you can see, the inner retinal hyperreflectivity is present in this case, and even the dark striations, if as mentioned, it is pretty much present. And as we go on, the clearing of the Sanfil over a period of 1 month, and if you can see from here till here, there's definitely a reduction in the retinal hyperreflectivity, and also the dark striae, which was present before, has definitely come down in this case. Now, coming to the next one is the Dawnfield. The Dawnfield is described as the dissociated optic nerve fiber layer, appearance of the fundus after idiopathic epiretinal membrane removal, as first described by Ramin Tadayoni in 2001. So he described it as a moth-eaten appearance, thinning and the dimpling of the NFL, and usually appears from 2 months or 3 months. And the traction during the ILMP, scarce Muller cells attachment. So these are the possibilities, and I'll come about why temporal more than nasal a little later. So it's actually not a loss of NFL. It's basically, the authors have described it because of the injury to the Muller cells. So because of the injury, after peeling an ILM, because of the injury, it leaves a cleavage in RNFL. And because of that cleavage, it causes the dimpling like this. And however, it has no effect on the visual acuity. The interesting paper in 2021, involvement of the anoikis in the dissociated optic nerve fiber layer, that is nothing but, they have mentioned it, it's probably an apoptosis kind of thing, which is happening. And because of which we see this kind of dimpling happening in the retinal nerve fiber layer. So they have also described in this paper by Francisco that the nasal PMB is thicker. Yes, because probably the contraction of the NFL after the ILM peeling causes reduction of the different distance between the ONH and to the fovea, what we call it as a papillofoveal distance. So because of the pulling of the papillofoveal distance, the temporal part of the retina starts thinning out. And that also could be the cause where we have an increased exaggerated kind of dimpling happening in the temporal part of the macula. So if you see, this is the another case, a traumatic mac hole, and basal linear diameter of around 1000 micron. And the patient here, we did an inverse ILM peeling, and the patient improved from 660 to 6/24 in this case. And if you look into this, we see here the dimpling, which appeared after 2 months of the surgery. However, it was a type 1 closure in this case, but however, you can definitely see the dimpling happening in the later frames. And as explained in the paper as well, if you can see here, this was taken at the 6 months, and then at the 2 years, when we go on, the dimpling starts appearing. So as we move on from month to years, they have described that the dimpling probably increases a little more. And this is another thing, we call it as a concentric macular dots, where we see here, it is usually of these Sanfil and Dawnfield are concentrated around the posterior pole. And on first OCT angiography, you can see these dot signs here, which is very clearly, and which is corresponding to this dimpling, or the we can say that a small wrinkling in the IL, they have mentioned it as a dimple. So this is corresponding to that concentric dots in the macular area. So how do we differentiate between these concentric dot macular spots versus due to Dawnfield and ILM folds. In the ILM folds, if you can see, because of the traction here, these are the wrinkling because of the traction, and they're usually the striate form of thing, which are almost like a centrifugal kind of appearance. Whereas in case of Dawnfield, we see the concentric dots here around the posterior pole. That is, if you see the fovea here, they are usually concentric around the fovea. So that's one difference how we can make it between the Dawnfield and the ILM folds. And the interesting paper in the Pioneer study have showed there is no changes irrespective of ILM peeling done, whether it is with a diamond dusted membrane scraper or the forceps. In another paper done by David Steele in 2015 have shown that there is more damage with the DDMS than the forceps. Yes, everybody has to agree. Some papers have also described the angulation at which it is done. And they have said that with these DDMS, if you take around 180 degrees of angulation when we peel the ILM, the damage is much lesser. However, with these forceps, we're trying to do it at 120 degree or 130 degree, which is almost a little bit acute as compared to the 80, which probably causes more damage to the retinal inner structures. Yes, thank you.
1 minute remaining, sir.
Yeah. So these are the macular hole closure patterns and updated classification. I'll not go into the more detail, but however, this is the nice classification. It's a good to read, especially when we are using so many neurosensory graft, when we are using the ILM flaps and when we are using the amniotic membrane. So these are the different types of closures which have been described in the recent December 2020 in the Graph's Archive of Ophthalmology. The last one is the outer retinal defects, that is the ORDs. It's nothing but the foveolar lucencies. Basically the defects in the outer retinal layers, including the EZ, ELM and the IZ, which is usually seen after the ILMP peeling. Majority of it have described it to be a cystoid space, that is the fluid filled cavity. But however, few papers have described it could be a degenerative as well. So these are the papers which says that the ORD associated with smaller macular holes and is associated with early pre-op stage and usually has a better visual outcome. They do not cause any defect like scotoma, as similar to Sanfield and Dawnfield, where they also do not have any scotoma or lessening of the visual acuity post-operatively. So the complete closure here has been mentioned as can be as 1 month and as late as 183. So this is our cases where this is the case 3, where we can see there's the full thickness macular hole and the basal linear diameter was around 1350 micron. And we can see here from 2 months, we can see there is a ORD here and it started regressing. The ORD started diminishing down, and over a period of 3 months, his vision improved from 636 to 6/9. So which it itself shows that it is not harmful. And second one is, this is again another patient with the full thickness macular hole. And here again, you can see the outer retinal defect here, which is gradually decreasing. So this was the inverse peeling done in this case. The MLD was around 450 to 500 micron with a basal linear diameter of 900 micron. And if you see over the time, it's almost the ORD has disappeared. And fantastically, this patient, to my surprise, improved from 636 to 6/9 parts. So which again indicates that these usually have a better visual prognosis and it doesn't cause any defect in the visual acuity. So there are a few other factors which also prognosticate. One is the ELM. The integrity of the ELM is very, very important. The EZ, as we all know, is very important. And also the cone outer segment tips line, what we call it as the cost, is also very important. The other prognostic factors in the visual recovery after the macular hole surgery. So I'd like to acknowledge the Department of Vitreoretina and especially our fellow, Dr. Rajeshri. Thank you very much for the patient listening.
Thanks a lot, Srinivas. As usual, a wonderful talk. I also came across that the occurrence of spontaneous retinal hemorrhages are seen in the nasal retina, especially where areas of dissociated retinal nerve fibers. I don't know whether it's just a chance or it is a consistent finding. The question
usually we see these petechial kind of hemorrhages after doing the ILM peeling, and usually they go off pretty much well. They don't cause much of damage because if you see most of the ILM peeling, some of these cases we tend to see where it is more thicker. Of course, various theories have been proved that the inner surface is smoother and the outer surface is rougher, which is directly connected to the Muller-Serre end plate foot processes. So peeling of this will not only damage the blood vessels at that area, superficial area, but also it might expose a little bit, and few of them have explained it to be a degenerative kind of process. And because of that degeneration, it forms a cleavage, and because of which the sinkage happens, and that is how they describe it as a Dawnfield.
So I have a question for either Dr. Anand or Dr. Mallika. So what would the precautions which you would take during macular hole surgery to avoid these kind of occurrences?
Okay.
Yeah. So the first thing is, of course, to be as gentle as possible. So all these are indirect, the Sanfield, Dawnfield are all evidence of iatrogenic trauma to some extent. And any surgery is traumatic. So you're making the 10-layered retina 9-layered. You're not removing vitreous, you're removing a part of the retina. So there has to be some level of trauma associated with it. And even in the cleanest cases, sometimes even if you do a pinch and peel with just one pinch and a complete 360-degree removal in one shot, one complete maculo ILM rexus, if I may call it that way, you will still see this petechial hemorrhages here and there. It happens to everybody. In some cases, it just absolutely doesn't happen. So this is a very random thing. I don't think we should, nitpick too deep into that. I would also just like to add that, I used to do initial phases where, our visualizing system was not that great. I used to do a lot of DDMS aided ILM, tap, lift the flaps. But then I also realized that was inducing a lot of, axonal trauma, and you used to see these white patches. And with imaging, as that improved, you could show that was Sanofi and later on, Dawnfield. So as our imaging capabilities increase, we are characterizing more of this iatrogenic trauma with possibly trying to read too much in it, but it's a good way of doing some sort of a postmortem analysis. So it's just that whichever instrument you use, I feel with the finesse, maybe you may be inducing a little more trauma, because with DDMS and with finesse, you're dragging across the surface. Whereas with the pinch and peel, you're picking up and you're pulling it out. So if you're able to do a clean pinch and peel, in my mind, that would probably have less of this. But that said, it's all in the hands of the surgeon, number one. Second thing, I'd just like to add with ORDs, I think again, that's an example of nitpicking. If you think of macular holes as it was described initially as pregnant drawbridge, two things together. So when these two come together, there will always be a gap below. So that is what I think is erroneously, or it's not something which is perfect, called as outer retinal defect. To my mind, you could just call it macular hole closure in evolution, or MHCI, if you want to. You do an OCT every day from the day of your surgery, you will find this in almost all cases. There's never going to be an absolute shutdown. So I'm just saying, sometimes imaging capabilities may be reading too much in this thing. As I think at last 2 or 3 cases that Srinivas showed, those defects were there, so-called defects were there, and then they went away. So it's just closure in evolution.
Dr. Mallika, you could add something on the precautions to be taken?
Yeah, I think Dr. Anand covered most of it. First of all, the Sanfield and Dawnfield are not bad prognostic signs. In themselves, they don't affect the vision. So we are not trying to really avoid those particularly. But yeah, we have to be gentle in ILM peeling. And sometimes we can leave the ILM. If it is very particularly sticky, parts of ILM can be left. It's not that macular hole will simply not close if you're not able to remove the ILM. So in some areas, you can even leave it and you may still get away with the hole closure. So instead of damaging the macula, simply to remove that piece of ILM.
Can I make
just to add to that point, just one
yes,
thing.
Dr.
People are doing a temporal flap closure. So leaving the entire nasal flap, people are talking about doing that also. So
I have also done that. I have done that several times, just the temporal flap and leaving the nasal, and it has not affected the closure rate.
I think, first of all, I agree with Dr. Mallika that it's really something which we really don't want to avoid, as it is harmless. And secondly, we really can't control whether a particular patient would show a Dawnfield in the post-operative period or not. If you allow me, I'll just show 1 or 2 images. Now, this is a very interesting patient. This patient had premacular hemorrhage due to Valsalva retinopathy. This patient underwent YAG hyaloidectomy. And because it was a sub-ILM hemorrhage, when the hemorrhage resolved, we saw that there was inner retinal dimpling, or what you call as Dawnfield. Now, this is something which shows that actually ILM peeling just itself is a factor which is responsible for inner retinal dimpling and nothing to do with this surgical trauma. So this paper was published in Canadian Journal of Ophthalmology. And after this, we came across this patient with aplastic anemia who had premacular hemorrhage and we did not do anything. And again, it was a subialam hemorrhage, and through the subialam hemorrhage, we could see that there was a dimpling. So if you, even if you factor in the factor of YAG energy, then you can consider that in the previous case, YAG energy could have caused Dawnfield. It could have caused some kind of damage. But in this particular patient, there was no energy, no peeling. So in spite of everything, this patient got inner retinal dimpling. And this paper was published in Ophthalmology. And this just basically, I want to stress on the fact that this is a pure simple, Dawnfield is pure simple effect of the ILM detaching from the retinal surface. And as Srinivas highlighted, that outer surface of the ILM is rough, and that's why we get these depressions on the surface of nerve fiber layer. And that is why Spade calls it inner retinal dimpling and not Dawnfield.
Thank you. We shall now go on to our next speaker, Dr. Malika Goel, and she is going to be talking on hyperreflective dots and hyperreflective walls. On to you, Doctor.
Good evening, everyone. I'd like to thank the ARC team and Dr. Chitra for this opportunity. Am I audible?
Yes.
Okay, so hyperreflective dots or foci were first seen by Koskes et al. In 2013. And these are small, very punctiform dot-like hyperreflective lesions, which can be seen in any of the layers of the retina, but mostly in the outer retinal layers, and are not confluent. They have greater reflectivity than the RPE. And importantly, they are not seen on clinical examination, fundus photography, or fluorescent angiography. These are only seen in the SD-OCT B scans. An important feature is that they do not cause shadowing despite their hyperreflectivity, unlike hard exudates and microaneurysms. As you can see in the right side, these are the other lesions, not HRF, which cause shadowing, unlike on the left side. And these can be seen in a wide variety of retinal problems, not just vascular, but also CSR, uveitis, even vitelliform and heredomacular degenerations, retinal arterial occlusions and venous occlusions, choroidal folds. Now, these are also sometimes seen in normalize and increase with age. And these are seen as hyperreflective dots in the base of the foveal floor between the ILM and IPL. And these are believed to be the Muller cells end feet or the ILM fibrils or vitreous hyalocytes. And since the Muller cell end feet are comprised of mitochondria, that might explain the hyperreflective nature of these lesions. So these are normalized, NFAS, OCT, and B scan, showing flat hyperreflective dots as well as elevated ones. And these are showing how these can increase with age from age 4 years to 85 years. Now, these were initially believed to be inflammatory, activated swollen cells or microglial cells because they are spread across all the retinal layers, and especially because they rapidly disappear during anti-VEGF or steroid treatment, but they recur whenever the disease becomes active again. So they are very rapidly appearing and disappearing. And also because there was a growing role that inflammation plays in AMD, so it was believed that these are inflammatory markers. Now, importantly, they may signify clinical activity and need for treatment. For example, this is a patient we had who we were watching with dry AMD and drusins, but you see when he developed fluid, there's a pocket of SRF, he also developed these hyperreflective foci. This is another patient who's being treated for AMD, and you can see that she develops these hyperreflective foci whenever she gets fluid, but at all other times, she does not have these lesions. So possibly they indicate or harbor, they're a harbinger of activity. If you start seeing these, you may expect that the patient may be reactivating. This was a study which showed that when the CNV, when the patient comes with active CNV at baseline, average number of HRF could be 12. Again, at reactivation, 12. But when the patient is inactive, the number of HRF is 4. So this is a clinical significance. What is the clinical significance in diabetic macular edema? The previous one was for AMD. In diabetic macular edema, if you see HRF, too many HRF, we have to be careful that when we start treating them, these may move posteriorly and accumulate, causing hard exudates, which if they are larger than 100 microns, hard exudates can appear, and especially in the foveal center, affecting the visual prognosis. So these are some images, not my own, which shows that hard exudates forming on treatment. So this is something we have to be careful about. What are the other theories of the pathogenesis apart from inflammation? It could be accumulation of pigment or proteins, lipid, lipoproteins, or extravasation from blood-retinal barrier breakdown in these diseases, or simply degenerated photoreceptors as in heredomacular degenerations or CRAO, BRAO, etc. These could be macrophages that have phagocytosed the degenerated photoreceptors. Now, do they have any prognostic significance? There are really conflicting reports. Some studies say that they have a good prognosis for anti-VEGF treatment. Some say that they are a poor prognostic sign and are associated with outer layer disruption, loss of and disruption and loss of visual prognosis. Also, there are conflicting types of results with anti-VEGF versus steroids, and there is no convincing data that steroid should be given when there is the presence of these versus anti-VEGF. And they're often associated with drill and other biomarkers, which may have poor prognosis. Now, this was one study which showed that bevacizumab non-responders tend to have a higher number of HRF, whereas dexamethasone responders have, bevacizumab responders have lower number of HRF, whereas the dex responders have a higher number of HRF, meaning that they may be more responsive to steroids compared to anti-VEGFs. But that's just one study. There's no convincing data. Now, as a corollary to this, they may accumulate in a ring shape in the cystoid spaces of DME and cause a pearl necklace sign. Again, the significance is that as they resolve, it may lead to hard exudates at the foveal center, causing poor visual prognosis, especially if the pearl necklace is away from the foveal center, at the foveal center. It may not affect the prognosis if it is extrafoveal. Here again, we see the pearl necklace intraretinal leading to hard exudates at the foveal center with treatment. So treatment can sometimes lead to worsening of the visual prognosis in the presence of large number of HRF. And lastly, we come to hyperreflective walls of cystoid spaces. I haven't personally looked at these or found these, but these are described as capsules of fibrotic tissues or fibrin in patients with DME. And these are because these are fibrotic, they maintain the structure of the cystoid spaces even with anti-VEGF treatment. Or they may not even be a fibrotic tissue. They may just correspond to cystoid macular degeneration, because some of them have been shown to have straight or concave borders. So this is how hyperreflective walls may be, and they do not respond to injections. So that's a poor prognostic sign and may be associated with other poor prognostic biomarkers such as disrupted EZ line and drill, which extend maybe longer, has been found to be longer in some studies with hyperreflective walls of cystoid spaces. And it is found in that DME remission at 18 months without these walls might be in up to 50% of the patients with treatment. But when these walls are present, the success rate reduces to 7%. So this may be an indicator of no remission with ranibizumab at 18 months. Thank you.
Thank you very much, Dr. Malika, for throwing light on these very relevant things which are coming up. But would it mean that having these hyperreflective foci is a poor prognosis, like these are the non-responders for anti-VEGF treatment? And would you think of trying steroid therapy in these eyes?
No, personally, I don't do that, Dr. Chitra, because the choice of steroid is always a second choice. Anti-VEGF is the drug of first choice. Steroid has too many side effects if the patient is phakic particularly, or the risk of raise. So I would not base my decision on this, and there is no convincing literature to say that it's required. There was the, even with regard to hard exudates, there is no convincing literature that steroids are superior. There's only one trial called the Bivordex trial, which showed that steroid may have a better effect, but by 2 years, both bevacizumab and dexamethasone had the same results. So really, there's no convincing data.
Srinivas?
Thank you. Yeah, thank you, madam. It was a wonderful talk.
Thank you. Thank you.
Yeah, my question to I think it's
Srinivas, there's some echo coming from your side.
Is it better?
Yeah, it's okay.
Yeah. Unni sir and Raja sir, I had a question to you all. So as madam nicely described, so there's the literature also says there are few HRF, which says 2 to 10, then comes moderate, 10 to 20, and then comes many, which is more than 21. And they say that the hyperreflective dots, if they are more closer to the RPE or the outer retinal layers, they are more prone for ELM or the EZ disruption, which is again can be considered as a poor prognostic factors. So how do we clinically really look into, when looking into the busy clinical practice? Do we keep counting at this? How do they actually relate in the clinical practice is first question. Second question is, as madam view is that, of course, in the first year, Bivodex also showed that Ozurdex is having a better hand, but in the second year, both Ozurdex as well as anti-VEGF both came pretty much of the similar issues. But still, when it comes to perifoveal hard exudates, somehow I must be biased that I still use Ozurdex in these patients. So what are your views on these two aspects? Unni sir first and then Anand sir.
So I presume we're talking about diabetic macular edema. And
yes.
So in this, what I believe that how do we treat these patients? I personally don't sit and count the number of HRF. But one point is that, as in anything in retinal practice, it's about pattern recognitions. So when you have the hard, there are two concepts, two things happening with HRF. One, as you said, the disruption of the outer retinal layers, which one could be due to a backscattering effect, and second, actual real disruption of the outer retinal layers also can happen. When we look at hard exudates, you're also looking as to whether these HRF are present in areas of spongiform edema, whether they are large turbid cysts, whether it is the pearl necklace signs. And we know by clinical practice that the presence of a large cyst with HRF and the pearl necklace line is very prone towards a subfoveal migration if it is very close to the fovea. So again, I also tend to use a little bit more Ozurdex when I see a lot of HRF, but it is not mandatory that I use it. Sometimes it's just to kick off the resolution of the edema before I go on to anti-VEGF. So yes, there are some key features. How close it is to the fovea and what is the nature of the edema is kind of more important for me than the number of HRF. And the HRF comes into more significance when I have a non-remitting DME, that is over a treatment time.
Quickly, Anand sir.
Yeah, so that's what. So I'd like to just underscore that, you asked for clinical relevance. I think the clinical relevance is only really there when you're reaching a case with non-response. I think this is seen from, this Wang study, which she mentioned. In that, I think two things to highlight, and I'll stick to DME again, that when you start having non-responders, you find 75% of them seem to have a lot of these dots. And when you have a lot of dots, HRF dots, they will not respond to anti-VEGF, but they will respond to steroids. So that is the clinical significance. When you, after 1, 2, 3 injections, you are beginning to get an impression, the clinician is beginning to get an impression that this patient is not responding the way it should. Then you start looking at the dots, go back and check whether these dots are increasing. And if you find the dots are increasing, edema is just staying where it is, that is a point for you to consider giving on that third visit either steroids with or without anti-VEGF.
Dr.
So
Anand
that is the clinical
Rajendran,
result.
Dr. Rajendran,
that is one thing.
But with or without the presence of HRF, in any case, if you're not getting a response with anti-VEGF, you would still now go to steroid. So it's not that you would go because you saw HRF.
No, that's what I'm saying. See, many people will not wait for 3 injections. Many people say non-response should be there after 6 injecns, after 5 injections. The entire definition is variable.
Yeah, okay.
So if you go to, say, for example, the Johns Hopkins, the Wilmer, Dr. Bressler's things, do not talk about non-response before 6 injections. And to some extent, even the European EU also, they like to go a good number. But what I'm saying, in our scenario, with the patient sitting in front, we can't have those parameters all the time. But if you find that there is a profusion of these dots, know that this is a patient who is heading towards, even if you go ahead with 3, 4, 5 injections, your response may not be as optimal as you might with, jumping in with a steroid injection, Ozurdex or what. And perhaps If you look at the larger trials, with the MEAD trial, which look at refractory DME, where they found great response with Ozurdex, perhaps this translates over a larger, in a statistical manner in these trials also. So I think that is where the relevance of this comes.
It's a very good point. Very good point.
Thank you, sir. Thank you. Thank you very much. I think we can go ahead. Thank
Thank
you,
you all.
Malika, madam.
Yeah.
Thank you.
Thanks a lot. Our next speaker is Dr. Ashray Naika, Senior Consultant, Vitro Retina Services and Uvia at the Eye Foundation Group of Hospitals, who has a dynamism, charm, and uniqueness of his own. And he is going to be talking on drill, BRP, and CMD. On to you.
Thank you, ma'am. Thank you, Srinivas sir, for the opportunity. So let's dive in. So this is the real world diabetic macular edema, where we see ellipsoid zone disruption, a large cystoid space, which progresses on to be a cystoid macular degeneration or a hyperreflective wall later on. Or there are broken septae, which are called as bridging retinal process, or the hard exudates, and of course the topic drill, that is disorganization of retinal inner layers. So coming to the drill, it is defined as inability to segment the boundaries of the inner nuclear layer, outer flexiform layer, and the ganglion cell layer and inner flexiform layer complex on OCT. Central 1000 microns to 3000 microns have been used by different studies as the area of interest. An additional parameter which has been very important is the foveal drill, which is the inability to distinguish boundaries between any of these inner retinal layers in more than 50% of the foveal 1 mm zone. So the Sun et al. Showed that described the mechanical pathogenesis of the drills due to macular edema that causes the stretching of neuronal cells. The Nicholson et al. Proposed an ischemic process describing a significant association between the presence of drills and the macular non-perfusion, which was evaluated on fluorescein angiography. This paper by Sanamo et al. Published this year showed the pathology as described by Nicholson et al. To be ischemic in nature. So you can see on OCTA, there is reduction in vessel density in superficial capillary plexus and deep capillary plexus, and a greater FAZ area in patients with drill in comparison to patients with no drill and normal OCTs. So there are after the Sun et al. Described about drill in 2014, quantification of drill was done differently by different authors, but this quantification by Grewal et al. Is very robust and repeatable. So what they did was they took one foveal scan and 3 above and 3 below at an interval of 238 microns. So they recorded serially on these 7 scans at every visit, and horizontal extent of the drill was measured in microns, and the vertical extent of the drill was defined as number of scans out of 7, with the drill calculated as a percentage. So this is a quite easy and well-defined method of quantifying drill. So coming to typical case, which would looks like this, with non-proliferative diabetic retinopathy with macular edema. You can see this cystoid macular edema with the parafoveal lipids. But on OCT, you can see there will be inability to distinguish all the 3 inner layers, and we can say that there is a drill. So in another case, they can be associated with parafoveal lipids and sometimes hard exudate plaque. And you can see this drill, and so I have subjectively measured it to be around 1732. So this variability in inter-observer thing has made it difficult for all the studies to have a correct dimension, because it can vary from OCT to OCT, from observer to observer, and the OCT apparatus to other apparatus. So drill is drill, interestingly, is not a fixed biomarker, and changes in drill over time have demonstrated prognostic value. And in drill, as described by Sun et al., evaluating patients with DME, an increase of drill by 300 microns correlated to one-line vision decline at 8 months, and conversely, a decrease in drill by 250 microns correlated to one-line drill improvement in vision at 4 months. So this was a case of a 54-year-old diabetic patient who was treated for chronic edema, had taken multiple injections and presented to us with vision of 624. And at that point of time, we gave 2 Accentrics, but there was not much difference. Then we switched to Ozurdex, and that is when we started to notice some resolution in drill. And so even though the edema has increased previously, but the drill had started to disappear, and that is when we noticed a small increase in vision. So then we gave the second Ozurdex, and the patient didn't improve with the vision, but edema subsided, but continued to have not more than vision of 6/18. And at various sections, it can vary from within the same OCT, it can be 1242 to 1298 microns. So this is a limitation of the drill. So drill again was described in diabetic retinopathy also, and the Joltikov et al. Studied patients in diabetic retinopathy and showed reduced retinal function is associated with reduced retinal thickness. And Onishi et al. Showed that regions of the retina with drill demonstrated significant perfusion deficits compared with adjacent control areas without drill. So, and drill can also be seen in other entities like branched retinal vein occlusion. And Babiuch et al. Demonstrated prognostic potential of baseline drill and drill burden throughout the treatment of visual acuity for patients with treatment-naive branch retinal vein occlusion and central or hemispheric vein occlusion. So this is another paper by Bala Ratnasingham et al., who demonstrated that there is enlarged FAZ and drill can be correlated and can be correlated well with the visual acuity also. So
1 minute remaining, sir.
So this is another case where the patient had a macular vein occlusion and ERM as well. So clinical implication is for each 100 micron increase in drill, there is a negative impact of approximate 6 letters, which is more than 1 line on ETDRS chart. And the paradoxical visual acuity changes, even with worsening visual acuity and resolving DME, patients with drill is usually more than 500 microns. And there can be worse visual acuity even with DME resolution. Conversely, there can be good vision despite having concurrent edema, which I showed in that case. So this is a case bridging retinal processes as described by Farhan et al. Are basically remnants of Muller cells and bipolar cells, and it can these usually resolve with good vision when treated, and usually can also be not associated with drill. And when these when these bridging processes break and become large, they are known to described as cystoid macular degeneration. With the dimensions have to be more than 450 microns horizontally and 300 microns vertically. So this is a case where there was no association with the drill. We always feel CMD is associated with drill. It can be independent of drill also. So this is a case where we treated the patient with Ozurdex. Patient had resolution of cystoid macular degeneration, but vision did not improve. So again, these are they don't really have visual acuity improvement. So drill, bridging retinal processes and cystoid macular degeneration are can coexist because they are part of the same pathological process, and depending on which section we take this thing, you can see a cystoid degeneration, bridging retinal process, and you can also see some drill here. So quantification has always been a limitation, and since there is no histopathological correlation, we really don't know what is the underlying pathogenesis. And very few small-scale studies have showed the relationship between drill and visual acuity. So with newer OCT platforms, it is automated, and the quantification of drill can be automated, and it can be used as a useful tool. And with any upcoming histopathological studies can really throw insights in how the pathogenesis of drill might be. And my take-home message would be, with the better resolution and more number of B scans being added to the OCT apparatus, it can be easily be identified with less ambiguity. And drill excellently correlates with severity and chronicity. And all these things are part of the same mechanism. And with new improved automated segmentation and AI, more than ever, this can be of more use in the coming days. Thank you.
Dr. Ashay, that was a wonderful talk, quite complex. But does it mean that its use is limited in clinical decision taking because it's sort of a late clinical marker and has less predictive value?
Ma'am, the problem is as I told you, the quantification is very difficult in these cases, because what is the extent of drill and how much when to treat and when not to treat, only we'll get to know at the end stage. So early detection in early cases, they do resolve, and actually drill can be reversed also. So we have seen that it reverses if it is treated early. So early identification is the key. So we need better resolution scans like swept source, and all those things can give us a lot of insight into how this occurs.
Dr. Srinivas?
Yes, madam. Do we have Girdhar sir also, expert panel? Girdhar sir, are you there?
I didn't see him.
Okay. I think we have Unni sir and Dr. Anand Rajendran here.
I am here. I'm very much here.
Okay, okay. Sir.
I went out for a short nap. Tell me.
Okay. So
yes,
I think Ashraya nicely explained about the drill, sir.
Yeah,
about
I have one question to ask.
Yeah.
Is there any study on Octa in eyes with drill?
Yes, sir. It has been published in this January 2021.
Yes.
So by Sanamo et al. So they have studied the correlation between the vessel density at superficial capillary plexus, deep capillary plexus, and the foveal avascular zone enlargement. So they have in the paper they have talked about that there is statistically significant difference between patients with drill and no drill. So the vessel density is what they have talked about.
Okay, thank you. Quick question to Dr. Unni and Dr. Anand sir. He has spoken most of the points regarding the disruption of the impulse, association with macular ischemia, good counseling tool. And he also mentioned about the reversibility of the drill and its association with the therapy, especially in the resistant and non-responsive cases. So I want to know your opinion about this on the reversibility of the drill and which agent to choose. And second question is to Ashraya, how will you differentiate between the wall of these cysts versus the BRPs, bridging retinal processes?
So, sir, that is the caveat. So that's what I showed that last image. So depending on what section you take, we call it as BRP or it is a cystoid degeneration. So
it's not that clear.
Hello.
Yeah.
Sir,
Yeah. You're audible.
Sir, that is the caveat. That's why it was described in 2014, because at what section you take the scan, whether the same thing can be bridging retinal processes, or in another angle it can look like a cystoid macular degeneration. It is very difficult to distinguish between these two on a certain scan. But at one section you can call it as remnants of these Muller cells and bipolar cells and call them as BRPs.
Yes, Anand sir. And
yeah, so I think drill is important. I never used to pay as much attention earlier as I do now in the last couple of years. I think there are, two or three real studies which I think some of them you quoted. The one by Jennifer Sun, the one by Usha Chakrabarti's group, I think Radha Das et al. So these are two keen ones, and one interesting one by Dr. Radwan et al. So drill is useful because it actually predates and correlates better with visual acuity than diabetic macular edema itself. And it also is better correlated with non-diabetic macular edema. I think you mentioned that very briefly, is that you see drill in not only diabetic macular edema, you see it in RBO macular edema also, RBO edema. So the correlation of drill with the resolution of edema and the acuity is better actually with non-DME macular edema than DME macular edema. And it also correlates better with visual acuity improvement trends than the macular edema itself. So therein lies the significance of drill, and that is why I don't think you should only look at it in late changes. When you see drill happening early, that should be a protector of trends. Now, also, I think you briefly mentioned that from the Radwan study we learned, but something very beautiful they showed us, that when you look at 4 time points. I think they looked at it over 4 months or 6 months or something, 4 time points. They classified them into early resolvers, late resolvers, then persistent, and those that don't resolve at all. In cases where diabetic macular edema improved. And they found that beautiful correlation was seen in visual acuity in cases which resolved early as well as those which resolved late. And it was a beautiful S-shaped continuum if you look at that graph. So there is a definite gain to be had from a trend point. Visual trend improvement point. You can portend, you can predict how a patient is going to improve by looking at how that drill is improving over time with your anti-VEGF treatment, even if the macular edema doesn't seem to be improving. So I think that's a beautiful thing which that Radwan study showed us, that in patients who improve early, within the first 2 months, when the drill goes away, macular edema may be coming down a little, those patients will end up with better acuity 6 months down the line. So that's a very strong thing that, if you do see a drill. So when you see that drill, do latch on to that, identify it, look at how it's trending over time with the anti-VEGF. That will give you something to talk about.
I agree. True, sir.
Thank you, Doctor. We shall now go on to our next speaker, Dr. Pukraj Ishi, who's back. A very eminent VR surgeon who, after a good stint in Shankar Nethralaya, Chennai, is presently based as Associate Professor, Retina and Ocular Oncology at the University of Nebraska Medical Center. So he is going to be talking on para-arcuate acute middle maculopathy. On to you, Doctor.
Thank you, Dr. Ramamurthy. I'd like to know if I'm audible, my slides are visible.
Yes,
sir.
All right.
You can go on the slideshow mode, please.
Slideshow. Thank you.
Yes.
That okay? Thank you.
Yes.
So in the next few minutes, I'll be talking about paracentral acute middle maculopathy. This was an entity originally described by David Saraf in 2013. And somehow correlated to another entity called acute macular neuroretinopathy. So I'll share one case of a 41-year-old male who had presented with complaints of decreased vision since 2 years. His past history was unremarkable except for having chickenpox in early childhood. And this is how his fundi looked. As you can make out, the right eye looks nearly normal. His visual acuity is 6.6 in both eyes. Left eye posterior pole is remarkable for whitish yellow diffuse deep retinal lesions supratemporal to the fovea. And if we look carefully, there are another speck of such lesions very close to the fovea. A closer look will highlight those images, and sometimes these are better appreciated on red-free images. And this is the larger lesion, and the second arrow points at the smaller lesions. The upper two pictures are fundus autofluorescence, and you can see hypoautofluorescence corresponding to the lesion that we saw on the clinical picture. The red-free image panel on the lower part of the slide also demonstrates whitish lesion, more highlighted because of the enhanced contrast on the red-free imaging. So this is the fundus autofluorescence. The early fluorescein angiography shows persistent hypofluorescence in the area of the lesion extending into the late phase. So looking at the OCT on the right side, the right eye looks essentially normal. The left eye, the scans passing through the supratemporal and lesion shows a large lesion. And if we trace the inner nuclear layer, it actually, you can trace a little bit right under this hyperreflective lesion on the OCT, and the NFL nicely drapes over it. So it suggests that the place of hypoperfusion or ischemia, transient ischemia, is essentially affecting the middle retinal layers. Also, the smaller lesion that was nasal to the fovea in the clinical picture looks like it's affecting the inner plexiform layer or the upper border of the inner nuclear layer. So this is a closer view of the OCT scan, and here you can make out the inner nuclear layer and the upper this lesion affecting the upper border of the inner nuclear layer. So the outer retinal layers are essentially preserved. Likewise, in the right eye, lesion affecting the middle retinal layers. So what do we see on OCT angiography? The superficial capillary plexus is unaffected, and this is a band-shaped lesion that is seen on the deep capillary plexus. So these are the views on the angioplex, superficial and deep, on first images. And we followed up this patient the last time we saw him at 2 months. Visual acuity was maintained, but there was very little difference in terms of lesion resolution, both in the large and the small lesions. Closer view, comparative panel at presentation, up and down at 2 months. Likewise, the smaller lesion at presentation and 2 months follow-up with minimal resolution on the smaller lesion. So management is observation. The understanding for this entity is evolving, and there have been increasing reports of a wide number of etiological conditions that can cause this. So we have been watching him and observing. Another case of a 40-year-old female who was a very sharp observer. She noticed a paracentral scotoma in her left eye since 7 months. Her past history was unremarkable except for hypothyroidism since 26 years. And the right eye is essentially normal. I was able to see a very granular, very subtle lesion here, nasal to the fovea in the left eye. Visual acuity was 6x. That, except that, so this is the area which was looking a little bit dull in appearance and a little bit granular. Nothing remarkable here on the autofluorescence. You can barely make out that there is a shade hypoautofluorescence here. And this is the red-free, very difficult to make out. Early fluorescein, nothing picked up on 10-2. The upper OCT is of the right eye, the left is the lower one. And if you notice and follow the foveal contour, you'll be able to make out there's this very, very subtle dip here on the nasal slope of the foveal dip. And there is some disruption in the outer plexiform layer, and maybe at the lower border of the inner nuclear layer. On-fast OCTA does not show too much on the superficial capillary plexus, but in the deep plexus, there appears to be some disruption. Likewise, on angioplex, we see some capillary dropout in the deeper capillary plexus. A multifocal ERG was able to pick up the difference in the threshold between the right and the left eyes. Again, this patient was observed and given an Amsler chart to help pick up any future lesions developing.
So you have 1 minute remaining.
So going to the etiology, we know that in the retina, we have the superficial, deep, and the intermediate capillary plexus, and they have vertical anastomotic channels between them. So the superficial is mainly within the ganglion cell layer, and the deep is along the end supplies, has a vascular supply up to the inner portion of the internuclear layer, while the deep capillary plexus supplies the outer retina and the inner part and the outer part of the inner nuclear layer. So basically, the inner nuclear layer is predominantly from the intermediate capillary plexus, and the outer plexiform layer predominantly from the deeper. Why do we see PAM here? Because this is a threshold between the inner and the outer capillary plexus, and also the FAZ is relatively avascular, and this area, parafoveal area, is prone to hypoperfusion and ischemic insults because it lies in the watershed-like region, which has a high perfusion demand and hence prone to ischemic insult. So as compared to cotton wool spots, which are more superficial, whiter, the PAM lesions are deeper, more grayish, and do not follow the distribution of the nerve fiber layer. And these are the differences in the acute and the chronic phase of cotton wool spot on the left, chronic on the right. Likewise, branch retinal artery occlusion has the entire inner retinal layers disorganized. In the PAM, the thickening is at the inner nuclear layer. So those are the important differences between PAM and AMN. AMN, different demographic profile. Females in their 30s, PAM is seen in males in their 50s and 60s. This is more at the inner nuclear layer. AMN is more at the outer plexiform layer. Sparing of the outer retina with PAM. Outer retinal defects are seen with AMN. And there are vasculopathic risk factors, as you can imagine, in the people in their 50s and 60s, but these females with acute macular neuroretinopathy are generally otherwise healthy. So these are the list of differentials that one should consider while seeing a patient with PAM. And the clinical presentation could be very subtle with paracentral negative scotomas. So similar representation of what we already spoke about. There are three patterns of PAM. Arteriolar gives us a band-like picture. On-fast OCTA, there's a fern-like when the venular side of the capillary network is affected, and there's a globular pattern in which the precapillary network is affected, and we will see examples of each. This is the band-like in our case 1, and this is the globular. The precapillary arterioles are affected, and this is the fern pattern in which the perivenular part of the capillary network is affected. So there is some subclassification and some understanding of the detail. Management remains observation, and there have been several reports of several vasculopathies, systemic vasculopathies being affected with PAM. Also, a lot of recent reports with COVID. So we can summarize to say that this is a clinical finding and not a disease entity. It can happen across different etiologies. There's a strong association with vascular risk factors, and a clinical correlation is of the utmost importance. These are my acknowledgements. Thank you for your attention.
Thank you very much, Dr. Rishi, for a wonderful talk. So much of examples shown. Does that mean that if there is no obvious ocular pathology and you see this PAM, you would need to investigate systemically with great dedication?
So yeah, so as you mentioned, often this will unmask an underlying etiology, but often, but there are certainly going to be cases which are going to be idiopathic, so to say, because you cannot put them in a bin. So in those cases, I would like to ask if the patient is young, if they are indulging in extreme sports or anything anecdotal like that. But if the patient is more in the 50s and 60s, then probably they share some risk factors with systemic vascular associations, and need to rule out common conditions like hypertension, diabetes, carotid vessel disease, and so forth.
Srinivas?
Yes, quickly we can ask. You are able to hear me?
There's a lot of
two systems in place.
Yeah.
I don't know why it is echoing. Yeah,
Now
now.
better. Yeah.
Yeah. So to our expert panelists, Anand sir and Uni sir, what is there a role of low molecular weight heparin in these cases of PAM? And secondly, post-COVID, I think Dr. Rishi sir, I wanted to ask, is there more incidence of PAM in these cases as it's an occlusive phenomenon? And what is any role of steroids in these kind of cases?
So basically, I think it's after all, PAM is after all an OCT condition. We are treating the patient, not the OCT. So it ultimately has to be driven by the underlying clinical condition. There have been a lot of recent reports, as you mentioned, with COVID. But again, the driver would be the severity of clinical indication. And if it's extrafoveal, near the vascular arcades, a few scattered PAM lesions here and there, and unilateral, then I would not be as aggressive. But if it's bilateral, if it's in the age group of 50s and 60s, if a patient is immunosuppressed, if the patient has vascular risk factors, then certainly that raises a red flag and calls for further investigation.
Anand sir and Uni sir, quick comments.
Yeah, so as first of all, good to see you, Pukraj, again. As he mentioned, PAM is something that we very often is a cause or a reason for unexplained visual loss. Patient recovers from an obvious vascular occlusion, and then you wonder why vision is not improved a lot, and then you look deeply, and then you find there is this PAM there. Or you find the patient comes with a very minimal, the fundus looks reasonably normal. But then when you look at the structural OCT, and this is why imaging has helped us, you see this middle maculopathy. And so I think that is the main thing. And you usually see PAM in, as you mentioned, elderly patients, and you see AMN more often in the younger patients. So this is one of the reasons for this is that, this is associated, AMN is associated with deeper levels or greater levels of ischemia. Whereas PAM, you don't often see it in younger patients because they're able to compensate for this, unlike elderly patients. So therefore, you do not see middle maculopathy as often in the younger patients because they're able to compensate for this watershed ischemic deficit. So that is one thing to remember. Of course, COVID has thrown entire thing off. You're seeing a lot of occlusions in patients that you should not be seeing. So I think that is the main thing to take home. about whether you need to treat every PAM. No, not necessarily. You can have 6/6 with PAM lying quietly. Patient may not even sometimes realize that they have a PAM there, and it could go off with them.
When you say treatment, anyway, what is the treatment? There is no treatment for PAM except no treatment actually.
Uni sir, anything to add from your side? No, treatment in the sense, madam, the few case reports have been shown where people have even tried the low molecular weight heparin also, although of course it could be as he showed it along with the branch retinal artery occlusion, where you see that there is the hyperreflectivity is increased in all the 6 inner retinal layers, probably in that, but there are few cases where they have even tried it. That's why I asked. I was curious to know. Uni sir, anything to add?
No, it's wonderfully said by Pukhraj and Anand. See, the basics, the intricate point here is that you're dealing with a disease, AMM, which has spilled over to PAM, where you have an inflammatory pathology spilling over to a slight vascular pathology. And that is where COVID sits in between all of this. So you can have small vessel damage because of COVID, which produces the PAM-like picture. And as Dr. Pukhraj has mentioned, this is a sign. The best treatment would be to stop looking at the OCT once it happens.
That's a good one. Yeah. So we shall now go on to Dr. Padmaja Kumari, who's a consultant retina and vitreous services at LVPI Hyderabad, a prolific surgeon, and she's going to talk on newer OCT markers and OCT angiography in diabetic retinopathy. Look forward to hearing you, doctor.
Are my slides visible?
Yes.
Yeah. Okay. Hello, everyone. At the outset, I would like to thank Dr. Chitra Ramurthy and ARC AIOS for giving me this opportunity. I would be discussing the role of OCT biomarkers, newer, and OCT angiography in diabetic retinopathy. Biomarkers are useful in detection of early disease, predicting the severity of disease, to monitor the role of therapeutic interventions, and also to prognosticate visual recovery. OCT biomarkers in DME, my earlier speakers may have stressed upon very nicely, but we can probably even classify as a negative and positive in relation to the visual acuity correlation. So it is important to look, very important whenever we see these biomarkers in the OCT, multiple exist. So it is important to look at the central 1 millimeter subfoveal zone, and that is where it's most important for the visual acuity correlation. And positive biomarkers are supposed to be the subfoveal neurosensory detachment or subretinal fluid. Then bridging retinal processes, they were supposed, as discussed earlier, it was like a vertical Muller cells, which can actually allow the transmission of visual impulses to photoreceptors, and a favorable biomarker. And increased basal choroidal thickness, suggesting that there is a lower degree of choroidal ischemia, is supposed to be also another favorable biomarker. So just don't look at only retina, but also in the choroid. Negative biomarkers like tractional element, like trot posterior halide membranes, drill, cysts in outer nuclear layer, especially if the cysts are large, more than 200 microns, they indicate the chronicity. And various necklaces have been very nicely elucidated by Mallika. So all those indicate chronicity and also poor prognostic factor. Integrate of axial limiting membrane, which is just like a basement membrane of photoreceptors, then ellipsoid zone integrity. Similarly, photoreceptor outer segment length, all these will indicate the health of the photoreceptor layer. Then hyperreflective retinal foci, again, was very nicely elucidated. And these hyperreflective foci, especially if they're getting accumulated, as you see these cases, if you see more in the outer layer, they indicate again the chronicity. Then another important thing is the hyperreflective choroidal foci. So you can see that, observe that this also has shown a correlation with the increasing severity of diabetic retinopathy. More hyperreflective choroidal foci have been noted in these cases. Similarly, another novel entity is a choroidal vascularity index, which is again shown to have correlation with the diabetic macular edema and as well as diabetic retinopathy severity. So when we just look at OCT, we see multiple biomarkers actually exist. Here, if you see, both the patients showed good anatomical response after anti-VEGF injection, but with different visual outcomes. So one can see presence of drill and hyperreflective retinal foci, and also choroidal foci, and a possible traction element, which is responsible for the negative visual outcome in this given scenario. Similarly, this example also shows again a poor visual recovery as there is a disruption of external limiting membrane and photoreceptors prior to the treatment. And even though there is a clinical resolution of the thickening of macula after the treatment with anti-VEGF injections. So this picture shows an example of patient with intact external limiting membrane with intact photoreceptor layer, shows good response with good visual recovery following anti-VEGF injections. Then one can see a favorable biomarker like subretinal fluid and also bridging retinal processes. And in this case, this patient at the baseline had very deranged diabetic profile and uncontrolled hypertension. Post-system control at 1 month showed good anatomical and visual outcomes without any intravitreal injections, which indicates that diabetes is a systemic disease. Systemic control plays a very huge important role, especially when they come with the baseline deranged profiles. So role of, let us look at now OCT. Role of OCT as a diagnostic, differentiation and follow-up tool in various scenarios of DR will be presented. So OCT angiography is a promising non-invasive modality for dialysis visualization of retinal and choroidal circulation. So a normal OCT can be divided into 4 levels: superficial, deep, outer retina and choriocapillaris level. So conventional FFA cannot image radial peripapillary loops, and also it cannot segment deep capillary networks, whereas OCT can image and segment all layers of retinal vasculature without any dye injection. So let us look at examples of area of interest in diabetic retinopathy. OCT has an advantage of accurate foveal avascular delineation in comparison to FFA in view of absence of dye leakage. Ischemic changes, perifoveal capillary dropouts, all can be analyzed both quantitatively and qualitatively on OCT. So another novel biomarker based on OCT is what we discussed previously as a hyperreflective retinal foci in the OCT can be actually detected as a suspended scattering particles in motion in the OCT. And these SSPM actually has been also shown actually to reduce with both time and as well as treatment as we treat these cases. And as they are completely resolved, they may clinically appear as actually as a hard exudate. OCT is again superior tool in measuring ischemia on both superficial and deep capillary plexus as shown here. And here one can see significant macular ischemia that is detected by OCT in a patient with type 1 diabetes mellitus. And new vessels on the disc actually can be seen more clearly in the vitreous phase of the slab of the OCT. And one can actually detect subtle neovascularization of the disc. For example, on the fundus picture, there is only a slight neovascularization. In FFA, you can see leakage corresponding to NVD, but in OCT, it not only can tell you the extent as well as the depth of the NVD very clearly. And this is a pregnant lady with a wispy NVD, which can be detected on OCT without an invasive investigation like FFA. OCT is useful in detection of NV and as well as capillary non-perfusion more clearly and the extent. Disc collaterals can show some leakage on FFA and can be confusing to differentiate from NVD, whereas OCT, these disc collaterals can be seen as a radial loop-like vessels, and they'll be more better seen in the RPC slab, whereas NVD will be seen more in the vitreous slab, clearly seen in vitreous slab. OCT is also very useful follow-up tool. Here one can see the regression of NVD after anti-VEGF and PRP. And active NV will show, also we can differentiate between active versus regressed, where active NV will show bright signal, whereas a regressed NV will show less white signal and reduced in calibre. And this third picture actually shows the 3x3 mm or 6x6 mm OCT limitation, where you can see that if the area of interest, if you could not image, the NV, the NV area can be missed. And even though actually clinically you can see that the NV has actually regressed here. And this limitation is now addressed by the role of wide angle OCT. So OCT also here you can see an example where there is a baseline active NVD with a white signal. After PRP, you can see that at 14 months when he came, there is still a small active remnant was there. After add PRP at the 1 year, after 3 months, you can see complete regression of NVD on OCT. Another scenario where it is a OCT can be a significant role is a case of foveal neovascularization, which can be obscured on the color fundus picture by the exudates or in the FFA by the background leakage. However, OCT can actually clearly demonstrate foveal neovascularization which indicates underlying severe choroidal vascular compromise. And these things can be usually seen in nephropathy patients. And also, FFA has been the gold standard for detection of neovascularization in asteroid hyalosis. However, ACTA is able to actually detect all these lesions comparable to FFA in cases of asteroid hyalosis. We also have shown in ultraviolet, in wide angle ACTA also, showing this neovascularization in cases with asteroid hyalosis. And ACTA also can predict the severity of DR. In an ongoing or prospective study, we found that there is a correlation between the severity of the diabetic retinopathy, both qualitatively and quantitatively, between the FAZ size in all the phases, both mild, moderate, severe, and PDR. There is an excellent correlation. And similarly, an interesting finding was when we compared color fundus wide field fundus photography with wide angle ACTA, the diabetic retinopathy level, which was supposed detected as a moderate diabetic retinopathy, has changed to PDR in 1/3 of cases, with a capillary detection of NVE in 13 eyes and NVD
one minute remaining.
NVD in 7 eyes. So future is wide angle ACTA. Here we show a case of clinically non-apparent neovascularization with just a streak of pre-retinal hemorrhage. And you can see that the wide angle ACTA actually could image clearly new vessels and capillary non-perfusion. So to conclude, OCT biomarkers and ACTA can help us to detect, predict, monitor, and also prognosticate visual recovery in diabetic macular edema and diabetic retinopathy. Thank you.
Thank you very much for a great detailed talk. Srinivas, would you take some questions?
Why it is happening like this?
Yeah. Maybe one very simple question I'll ask. Identifying microaneurysms through OCT angiography, how does it differ from FFA?
Yeah, very good question. So that microaneurysms can be picked up on ACTA, but again, ACTA can actually pick up the lesions which are depending on the flow intensity. So if the microaneurysm is having a high flow, it can be detected as a circular lesions. So I only shown the lesions which can be very confidently picked up by ACTA, but sometimes it can miss. So I won't recommend ACTA as a screening tool for detecting mild NPDR, but definitely ACTA will have a very clear-cut role in those cases of moderate diabetic retinopathy, where we have seen that even 1/3 of cases, actually diabetic retinopathy level can change from moderate NPDR to PDR, where NVEs and capillary non-perfusions, more severe changes can be more quantified based on ACTA.
Thank you.
Thank you, madam. Thank you so much. That was a nice talk. I just wanted you to highlight a little bit about the choroidal biomarkers also. Do we really look into the choroidal biomarkers? You have very nicely explained about the OCT and the OCTA biomarkers, where we know that the thinning of the choroid in diabetes, it can lead to choriocapillaris atrophy and the capillary dropout. And they have even indicated that the thicker choroid may be indicative of more VEGF driven and responds more to anti-VEGF therapy than with the thinner choroids, which may have the non-VEGF mediator also, and therefore less responsive to anti-VEGF therapy. So where are we now? Are we looking into the choroidal biomarkers also at any time?
Yes, I mean, so there is definitely a significant literature is now evolving, where even the more common change that was noted is about the Haller layer. If the Haller layer is thinner, and there is a quantification software, so actually Rupesh Agarwal et al., they have done excellent literature, and where it is again like a research tool. In the clinically, they have used a protocol and quantified Haller's layer, and they said that the Haller layer can be thinned out even before diabetic retinopathy changes can actually come. So it is something like an early marker. So what I would say is that in a clinical way, when I want to utilize, like for example, whether it is a choroidal vascular index, it is again shown to reduce. So there are calculations like lumen area and total area. So these tools to come into, for example, whenever you say quantification tools, as a clinician, when I look at it, unless it comes as an automatic, like how Ashray told, like the machine gives after this image and it can enable the lumen index and it comes, then probably it becomes much more significant. Otherwise, definitely choroid is a very much interest area. As I said, the choroidal thickness is something definitely we can look at it, baseline choroidal thickness and how it is responding. So if there is a basal choroidal thickness is more, they are supposed to have more good response for your
Better
anti-VEGF
prognostic
treatment.
impact. I agree, madam. Unni sir, anything you want to add?
No, when we talk about choroidal imaging in DR, we're just touching the tip of the iceberg by talking about thickness. There are, the Dr. Agarwal's group has actually talked about the CVI. We're talking about adaptive optics, identifying choroidal vascular microaneurysms, choroidal angulations, choroidal, pruned vessels in the choroid. So the concept is in two parts. One is that how much of choroidal ischemia is contributing towards driving the retinal process inside the eye. So it is a very key feature over there, and that is where all the future evaluation, including on-fast imaging, adaptive optics, even your electron microscopy is pointed at looking at the qualitative choroidal vascular changes, not just the metrics.
Thank you, sir.
Yeah, if I may just add one point,
Anand sir,
Padmaja mentioned that, it's not as important in, the milder stages, and perhaps it's a greater use in documenting, at least for the same. I agree with that completely. I think that's it. But, going forward, we are now kind of obsessed with, AI detection in diabetic retinopathy. And tomorrow, what's going to happen is the AI is going to get married with Opta, especially wide field Opta. And the great area of interest is in preclinical detection of diabetic retinopathy. There are so many indices coming up, avascularity zone, the FSZ, the paravascular flow density rates, the axis ratio, the circularity ratio, how circular the FSZ is compared to a projected circle. So all these indices are slowly coming in, and all these indices are based on Opta. So tomorrow you're going to find early detection of diabetic retinopathy being brought in a few years' time with AI, and all these indices are going to play a role there. So I just want to bring in that aspect of diabetic retinopathy and the role of Opta, which is going to see probably in about half a decade from now.
Thank you very much, Dr. Anand. Srinivas, we have 4 more speakers, so we have to be conscious.
Yes, madam. Go ahead.
I don't want my last speakers to lose out. We have with us Dr. Giridhar, who's going to be talking on OCT and OCTA in central serous retinopathy. Look forward to hearing from you, Doctor. Dr. Giridhar? What has happened? He was here, no?
I'm here. I'm very much here.
Okay.
I thought again you went for a nap, sir.
No, I didn't go for a nap. I'm very much here. I'm just getting my thing onto the screen.
Yeah, keen to hear from you, sir. Please go ahead.
You can see my presentation?
Yes, sir, but not in full screen mode.
Not in full screen.
I will do that. Yeah.
Yes.
Yes, yeah. Yes.
So anyway, at the outset, thank you for having me in this webinar, my first webinar in 2021. So I'll be talking on OCT and Opta and central serous chorioretinopathy. So OCT is a very important modality of investigation in central serous chorioretinopathy. It aids in diagnosis. It's very important to understand the pathogenesis of disease. Actually, a lot of understanding of the disease has come in after we started doing ST-OCT. It's got an important role in prognosis and also in the follow-up of patients with central serous chorioretinopathy. This is my first slide. Now we have 4 pictures showing you serous macular detachment. The top one shows you a clear serous macular detachment with a thick choroid. This one shows you a serous macular detachment with an irregular flat retinal pigment epithelium. This shows you loculated fluid. And this again shows you a serous macular detachment with a very circular symmetrical lesion which was present in the other eye also. So this is a classic case of central serous chorioretinopathy. This is not CSCR. Once you see this flat irregular PED with a hyperreflective area between the retinal pigment epithelium and the Bruch's membrane, you are probably having a neovascular network. This is an inflammatory lesion, and this is what we call as Best disease, which often is misdiagnosed as central serous chorioretinopathy. So SD-OCT is very important, and I will start from the choroid. So years ago, we understood once we started doing the SD-OCT, especially into the choroid, the EDI, we saw that the choroidal thickness is increased in central serous chorioretinopathy. And this is not only in the eyes that are affected with the disease, but also in the fellow eye, meaning thereby that the choroid it's primarily a choroidopathy, which finally results in leakage of fluid into the subretinal space because of a small defect in the retinal pigment epithelium. Apart from increase in the choroid thickness, we also see in some selected cases enlargement of the outer choroid vessel, compressing the inner choroid, and thereby resulting in ischemia of the outer layers, which can cause significant decrease in vision over a period of time. This also is otherwise known as diffuse retinal pigment epitheliopathy, which is usually bilateral and sometimes symmetrical, as in this particular case with a peripapillary pachychoroid syndrome. From the choroid, we move on to the retinal pigment epithelium. There are multiple changes that we see in retinal pigment epithelium in central serous chorioretinopathy, and the most common is what we call as a serous pigment epithelial detachment, which is seen between 50 to 100% of eyes with CSCR, and this can be present either within the SMD or outside the SMD. We can also get large dome-shaped PED, serous PEDs in central serous chorioretinopathy, and we should always remember that the size of the PED may be larger than normal in certain specific cases of central serous chorioretinopathy. Apart from the PED, the most important finding is a focal RP rip, or a defect in the retinal pigment epithelium, and it has been shown that this is the area of leak using the fundus fluorescein angiography. Therefore, this small rip acts as a conduit for collection of fluid in the subretinal space. Small retinal pigment hyperreflectivity also can be seen in central serous chorioretinopathy, and this also could be small areas of RP leak in CSCR. Therefore, this is a patient with a fibrinous central serous chorioretinopathy, where we found the small RP rip right at the summit of this lesion, and this was a pregnant lady with very poor vision, for which I gave focal laser to the RP lip without fundus fluorescein angiography, and post-treatment within a month there was complete resolution, and this was reported by us years ago in the retina cases and brief reports. And this is a very important utility of understanding the presence of an RP rip. Some of the other changes that we see is the presence of hyperreflectivity within the serous macular detachment. This may be focal hyperreflective dots or a diffuse hyperreflectivity because of a fibrinous exudation. And this again is a very important finding, which we had described a couple of years ago, where we analyzed a large series of patients with fibrinous central serous chorioretinopathy, and we showed what we described as a vacuole sign, which is adjacent to an RP rip or a defect in the retinal pigment epithelium. And what we speculated at that time was that probably clear fluid leaking from the choriocapillaries collect within this particular space and push the fibrinous material to the side. And this is a very important finding. And again, these are areas of leakage in fundus fluorescein angiogram. Here again, you can see a beautiful picture which can show the RP rip and the leakage corresponding to that particular area from the same series. Apart from this, the other important finding in the retinal pigment epithelium is what was described as a double-layered sign, and we had done a lot of work a couple of years ago and understanding the DLS in various choroidal pachychoroid disorders. In a central serous chorioretinopathy, we see it in about 28 to 30% of eyes, and most importantly, it's very small in length, and the space between the retinal pigment epithelium and Brooks membranes is uniformly hyperreflective when compared to the neovascular network, which grows between the Brooks membrane and the retinal pigment epithelium, where we find it a uniform hyperreflectivity, as you can see, and this was again reported by us a couple of years ago. Coming to the serous macular detachment, it's very important to understand that once it's very clear, it's an acute CSCR. And once you see these sort of hyperreflective dots or a hyperreflective layer overhanging the roof of the serous macular detachment, these are signs of chronicity of the disease. Another important finding in chronic disease is the presence of cystoid changes. And these cystoid changes are present with significant abnormalities in the retinal pigment epithelium, which may be distortion or or atrophy, or sometimes even hypertrophy of the retinal pigment epithelium. It's important once the patients reach this particular stage to rule out choroidal neovascularization. Chronic diseases can result in a degenerative cystoid. OCT is important in follow-up, and in follow-up, what I would like to say is that patients need to be followed up till the macula is dry. This is very, very important in CSCR, because only then you know that this particular
1 minute remaining,
has
sir.
completely subsided. I think I'll take a little time. So OCTA in CSCR is very, very important, especially in elderly patients with CSCR over the age of 50 years, recurrent disease, and also it has got very diagnostic OCT findings in patients with characteristic CSCR. We need to do an OCTA. Now, I will just show you this particular case of chronic central serous chorioretinopathy, where you see this irregularity of the retinal pigment epithelium and this hyperreflectivity in the just above the retinal pigment epithelium, strongly suggestive of possible neovascular network. But OCTA did not show any network when in this particular case, including the ICGA and the FFA. Therefore, this was only a case of a chronic central serous chorioretinopathy, which responded to conservative management. However, this is another case to show you the flat irregular PED and showing you a neovascular network corresponding to the particular area. And this, again, this is just to show you how OCT is very important to probably tell us which are the cases where we have to do where we have to do an OCTA. Here you can see beautifully the flat irregular PED with a hyperreflectivity corresponding to that area. You can see this neovascular network in OCTA. So I will show you 1 or 2 cases. This is a very beautiful case which was diagnosed initially as a CSR, where there is complete resolution, and subsequently the patient came back with a small hyperreflective area and minimal intraretinal fluid, suggestive of possibly a neovascular network. And you can see a large neovascular network. Therefore, subtle changes in OCT should be an indicator for doing an OCTA in some of these patients. This is again an elderly patient with central serous chorioretinopathy, where OCTA initially did not show any network, but subsequently, or after 1 year, the patient came back with again a near normal visual acuity with this flat irregular PED. At that time, he could see the type 1 neovascular network growing under the within the flat irregular PED. Therefore, the presence of a tract like this need not necessarily mean always a central serous chorioretinopathy, and some of these patients, especially in chronic disease, can harbor a neovascular network. Therefore, in conclusion, I would say that OCT and OCTA are very important diagnostic modalities in central serous chorioretinopathy, and there are specific indications for use of OCTA in CSCR. Thank you all for your kind attention.
Thanks a lot, Dr. Girdhar. That was an amazing talk. Srinivas, could you take some question? I don't think there's much to ask. He has said it all.
Yeah, I think I agree with your point, madam. We can have few points from the panelists, Dr. Unni and Dr. Anand Rajendran, please.
Just one of them, because we have 3 more speakers.
Yeah. Yes, Dr. Anand, sir.
Yeah, no, I think Girdhar has very elegantly given us a complete overview and where all this is important. I think specific just to touch upon the role of OCTA, I think that's very important, especially when you have a lot of fibrin. The entire leakage may get obfuscated. So I think that is one clear place where you like to follow this patient with OCTA to see if a membrane is slowly developing under that. I think that is a key use of OCTA. There have been a lot of descriptions of OCTA patterns, different angle patterns and everything. But I think the key thing is to be able to identify that and the decision as to whether you need to put an anti-VEGF for a secondary CNVM coming in. That's the key use of Octa with CSR. I think the rest, Dr. Giridhar has again spoken about.
How would you differentiate a false positive choroidal neovascular membrane by Octa?
Dr. Giridhar, would you like to take that?
Pardon?
Can you press? Yeah, sure. Go
Pardon?
ahead, sir. Go ahead. Yeah, go ahead, sir.
No, I mean, how do you differentiate? No, the thing is that basically, I mean, see, in a classic, see, you have to differentiate between a CSCR, the type 1 neovascular network, and post CSR CNVM. Now they are both different. Post CSR CNVM is always a type 2 membrane, where even in fluorescein angiography, you'll get a very good leak. Whereas type 1 neovascular network that we are now seeing in many of these patients, especially who are diagnosed as CSR earlier, couple of years earlier, and who come back with recurrent episodes later in life. Now, these are the patients who are coming with type 1, where Octa is very useful because ICGA and FFA may fail to detect the neovascular network.
Thank you. Thank you. Thank you.
One last question, Giridhar sir. Sir, how will you differentiate between, is there a difference between the PNV and the CNVM developing secondary to chronic CSCR?
No, that's what I said. There's the CNVM, see, actually, recently there was one article in Retina, which the title of the article was choroidal CNVM in CSR. Now, all the cases that they have shown are type 1. That is between the Bruch's membrane and the retinal pigment epithelium. Okay, whereas in classic post-CSCR CNVM, it is always a type 2, where I showed one patient there, where it was a type 2 network. That is a classic post-CSCR CNVM, which is usually a type 2 network. So the PCN, what you're calling, is a type 1 network, where we have the flat irregular PED and that, hyperreflective PED long area. So that's the one, that is the type 1.
Thank you.
Thank you.
We have with us Dr. Sharunan, who's the Chief of Vitreous Retina Services at Arvind Eye Care System, Coimbatore, an amazing surgeon and a knowledge bank with a modesty beyond his prowess. And he's going to be talking on multi-layer PED and lateral elongation of fibrovascular PED. On to you, Doctor.
Thank you, ma'am. I'd like to share my screen now. 1 second. I have some issue with the. Can you just go on to the next speaker? I'll just get this ready by the time.
Yeah, sure. Look forward to your talk. So get back to us soon. We have with us Dr. Madhu Kumar, Consultant VR Services, Shankara Eye Hospital, Guntur, and he is going to talk on outer retinal tubulations and subacute hyperreflective material. On to you, Doctor.
Thank you, ma'am, and thank you, ERC, for having me here. I'll share my screen now. So, can you see my slides, ma'am, now?
Yes.
Okay. So good evening, everyone. So I'll be speaking about the outer retinal tubulations and subretinal hyperreflective material. Just a minute. Okay. So what's a biomarker? It's a morphological and structural alteration that can provide an important information about the stage of the disease. Now, since the invention of OCT, it has changed the way we look at the retinal diseases by a large means. So OCT biomarkers, especially in AMD, it gives us information regarding the staging, personalizing a treatment depending on that particular eye or the stage of the disease, and following up the patient and to see whether the patient is getting better, that particular eye is getting better or it's getting worse or resistant, and of course to prognosis. So largely OCT biomarkers in AMD, in neovascular AMD, can be divided into 2 categories. One is based on the retinal distribution of fluids, that is the intraretinal cystic fluids, that is IRC, subretinal fluids, SRF, or pigment epithelial detachments. Coming to the structural OCT biomarkers, the photoreceptor layer integrity, that is the ELM, EZ, and IZ, the hyperreflective dots, which is already covered, and I'll be speaking about the ORT, that is outer retinal tubulations, and the subretinal hyperreflective materials. So coming to the ORT, the term was coined by Zweifel et al. They are the branching tubular structures which are located in the outer nuclear layer of the retina. And they are circular in or ovoid in shape with a hyperreflective band, typically around a hyperreflective core. It's observed in a variety of degenerative diseases of outer retina. First, it was identified in neovascular AMD. It is also seen in atrophic AMDs. And it's just not restricted to the AMDs. It's also seen in the regenerative retinal disorders like an RP, Garrett atrophy, choroideremia, CSR, Stargardt's, and certain diseases. The pathophysiology is not yet completely understood, but it is usually seen in the long-standing retinal degenerative processes. Essentially, it is the rearrangement of the photoreceptor cells and the nuclear cells as a result of a reparative attempt to a retinal degenerative process or in response to an injury. Usually, it is associated with a dysmorphic or an absent RPE. Histologically, it is divided into a nascent, mature, degenerative, and end stage. Essentially, it involves the degeneration of inner and outer segments of the cones. Later, the outer segments lose out, and in the end, only the ELM remains, which is the end stage. Coming to the OCT features, Preti et al. Give an excellent idea of how evolution of outer retinal tubulation happens. So to begin with, we have an RP atrophy and an overlying CMVM or a fibrotic membrane. So over that, the ELM starts falling down. That is, it starts dipping down. So this is the dipping down of ELM, and then it kind of abuts the overlying fibrotic tissue. So this is called an open ORT. Now this large ORT again gets divided into 2 or 3 smaller ORTs. When these smaller ORTs are being formed, the autoplexiform layer, that is the OPL subsidence sign, where the OPL dips down between the 2 ORTs, causing the traction on the ganglion cell and the other layers of the retina, inner layers of retina, which causes small cystoid spaces, which are not fluids, but these are actually because of the traction on the retinal layers. So in the end, the ORT takes its usual feature of a circular hyperreflective layer with the center hyperreflective layer. Now, what are the different forms of ORT? This is essential because when we say ORT, when we interpret an OCT, it doesn't mean that all the time we have to look at the a circular one. So it can be a forming ORT where the ELM dips down. It can be an open ORT where the ends are abutting the fibroscular tissue, or it is a closed ORT, or an OPL subsidence where the OPL layer dips down. And this small microcystic lesion should not be confused with the fluid. This is how it looks in an ENFAS OCT. It's also seen in, as I mentioned, Best disease, retinitis pigmentosa, you can see here, Stargardt's disease. So what literature suggested is overall it is in 30% of the NV cases which are treated with anti-VEGF. At baseline, it is 2.5%, and at 4 years, it is 41%. So incidence increases despite anti-VEGF treatment, slightly lesser incidence in monthly regime compared to PRN and treat and extend regime. It presents at the atrophy as a higher risk. So what Catrell told us was that lower BCVA is seen in patients with ORT compared to those with no ORT, lower treatment benefits in the eyes with ORT. Eyes with lower BCVA at the baseline tend to develop ORT more rapidly, and it may be considered as an indicator of severity. So Dolce-Marco et al. Gave a timeline of how ORT can mature from flat to the typical ORT from 7 months to 17 months. So clinical significance, it has a prognostic value, advanced disruption of the outer retina, its presence suggests poor visual functions. In eyes with neovascularization, the hyporeflective ORT should not be misdiagnosed as an intraretinal subretinal fluid. Its recognition is process separate from exudation may avoid unnecessary treatment. To summarize, the degenerative process. The process and the forms are key in making decisions. Now coming to subretinal hyperreflective material, it's an OCT feature seen as a hyperreflective material located between the neurosensor retina and RP. It is formed of fluid, fibrin, blood, scar, or fibroscular tissue. It may change with the time or with the treatment. So subretinal hyperreflective material, eyes with a SREM have worse visual acuity. If they involve fovea, that eye will be adversely affected. If they are thick and wide, again, those eyes will perform badly because this can appear as a mechanical barrier and damage the overlying photoreceptors. The width affects more than the height because it can prevent the eccentrical fixation. Scar develops more often in eyes with SREM. Anti-VEGF therapy and SREM, significant decrease is seen within 4 weeks of therapy initiation, and it becomes slowly after that. This is because the fluid component is dried up by the anti-VEGF. Later, it is the fibrotic component, which takes more time. Coming to the literature, increased reflectivity and well-defined borders suggestive of fibrotic tissue or mature and neovascular complexes prove that it is towards the fag end, that is it will be a worse prognosis. Associated with IRF or EZ loss, again, it points towards the poor prognosis. SREM clearly distinguished from RP or not doesn't make any difference in the prognosis. Just 1 or 2 cases. Now, this was one thing I want to highlight is no matter how many OCT markers we have or what distinguish we have, nothing can compensate a good clinical examination because it is up to us to decide what investigation it is. So this is a case of a PCV. You can see that there's a SREM here, and there is a cystoid spaces and SRF in PED. Octa showed some detectable flow signal in the SREM. FFA and ICGA showed a polyps, but no BVM. The patient underwent intraoral injection of ranibizumab followed by full-fluence PDT. Now the SREM almost comes down with a good response.
1 minute remaining, sir.
Yeah, just 2 more slides. This is second case, another case of PCV. If you see here, there's only SREM, but there is no fluid. So patient underwent Octa. This did not pick up any polyps. Detectable flow was there in the Octa. On an ICG and FA, we did see polyps, but there was no fluid. So we followed up the patient for a couple of weeks. Later, the fluid appeared. And again, the patient underwent intraoral Eylea followed by full-fluence PDT, and it responded. So to conclude, one thing I want to highlight is no matter how many biomarkers or what we have, it just equips us to make decisions and say like, okay, this patient is doing well or this eye is responding to the treatment. And in presence of the ORT or SREM, it makes us be prepared to explain the patient or to expect that the visual prognosis is not going to be great the moment they appear or once they start consolidating. So they help us in individualizing the treatment, be it from the beginning or to change the treatment subsequently, decide when to stop aggressive treatment because we all know how costly affair it is to treat with anti-VEGF treatments. And good clinical examination and multimodal imaging is the key. So future treatment protocols may be based on these markers. Thank you.
Thank you, Madhu sir. I think that was a fantastic talk from your side. Just one question regarding the SREM. It's a very vague terminology. As we know, it can present as a blood, it can be a scar, it can be a CNVM membrane, or it can be a hard exudates clumps as you showed. So is there any indication that these are the SREMs definitely which require to confirm with the OCTA or with the fluorescent angiography, and these are the SREMs which needs treatment? Any specific characteristic would you like to tell upon?
Yeah, so right now at the present moment, SREM is it's a vague term. It, as I mentioned, it consists of the fibrin, blood, and all these products put together, and probably a part of the CNVM itself, and it changes its morphology or the consistency with subsequent treatment or the time. So it is essentially we need to look into it as a changing pattern, And multimodal imaging, as I said, is more important. So just looking at it in an OCT and
It
deciding
would
that
not
this
be possible. Any quick comment from Unni, sir?
There is a new, the new international thing on the SHREM has now eliminated the presence of blood from the definition of SHREM. And it is now turning towards SHE, that is SHE, subretinal hyperreflective exudation. So that is one thing. And the second thing is that now the characterization of SHREM itself has gone into something called vascular and avascular SHREM. The indication when you talk about vascular SHREM is that it contains a CNVM component inside. And when you talk about an avascular SHREM, that there is the hyperreflective material, there is no contributory vascular events inside. For this definition, the octa is going to be invaluable. Why this is important is that when there are vascular elements, the possibility of the SHREM persisting and converting into scar tissue is more as compared to when the SHREM is avascular. Now let us bear the fact, like PAM, SHREM is an OCT feature. It is not a clinical disease, and therefore it is not yet, let me say, homogeneous. That is the best term. The definition is not homogeneous yet. Neither is the SHREM. Thank you.
Thank you, sir. We can move ahead with the next speaker, Dr. Saravanan, sir. You can go ahead.
Thanks, Srinivas. So this will be, can you see my slides now?
Yes,
Yes, sir. Yes.
So we have been seeing a lot of new definitions as well as new biomarkers coming up, and this has greatly altered the understanding of what we treat and prognosticate. So I'm just showing, starting with a case of mine, an old man with the bilateral wet AMD. Right eye had multiple injections of anti-VEGF, and you can see it's partly scarred. And you look at this typical sort of lamellar appearance, which was first described by Spade et al. In one of his articles. And this eye was more or less not very good, and but I started losing in the vision in the left eye, and you can see here the large PED with the vascular component underlying the RPE, as well as the sort of empty space here, which we'll be seeing what this means and how we go with these eyes. So this patient actually went on to get 3 injections of Rasumab injection, and he did not show much of a response in spite of getting, and now he is being trying to counsel him for a Paginax, and he's still yet to decide. This is the last visit approximately 1-2.5 months back. This was his appearance. He has not come back yet. But anyway, so why we see this this sort of a multi-lamellar or layered appearance is because of when you're dealing with a wet AMD and a choroidal neovascular membrane, it's not only a neovascular ingrowth. It also contains inflammatory cells, fibroblasts, myofibroblasts, glial cells, as well as RPE cells. And when you keep on treating them as a healing response, these tend to regress and then progress and then regress whenever you give. So anti-VEGF therapy, whenever you try to remove the growth stimulus by giving anti-VEGF therapy, the vascular element sort of decreases and the inflammatory and fibrotic elements sort of predominate and leading to formation of this lamellar component. So these fill up more of the sub-RP component of the fibroscular PED, and then as when you give multiple injection, every time the inflammation comes back, the vascular growth comes back, and then you inject and the fibrotic element takes over. So you get multiple lamellae, and this is the picture from the Ehsan Rahimi et al. Article from Retina. So they showed this typical appearance which you see in chronically treated CNVMs. So this is the top line is the RPE. And just below the RP, you have the active vascular component, and below that you see the multiple fibrovascular, the fibrotic elements, which sort of healed response to previous injections. And then below that you see a hyporeflective area, which they termed as a prechoroidal cleft, which we'll be seeing later. Sorry. So this is again the picture from the article. So you can see that the lamellae, multiple lamellae, which are the fibrocellular elements, and above that is the some it's a homogeneous. Just below the RP, you see a homogeneous layer which indicates the active vessel neovascular tissue, and sometimes it can be in a round or tubular shape, which again is part of the vascular group. And below the lamellae, you see this sort of concave lesion, which is the prechoroidal cleft. So they hypothesis that the exudation from the overlying synovium complex can precipitate on the surface of the Brooks membrane, where the lower density fluid components are filtered out. So the remaining fibrin may serve as a scaffold for the blood vessels ingrowth and also the connective tissue formation. And because of this, the fusiform spindle-shaped appearance is seen because of the organized layers, multiple homogeneous hyperactive bands. So these multiple layered bands are comprised of fibrocellular tissue, which contractile properties result in the spindle-shaped appearance. So even though it's quite a dramatic appearance to see these multiple lamellae, because it's all the lesions is below the underlying the RP, and this neurosensory retina is more or less maintained, anatomy is more or less maintained. So a lot of eyes have a good vision despite the spectacular appearance which you see below the RP. And also the hypothesis that sometimes this can be act as a surrogate for the chorea capillaris and provide oxygen and nutritional support to the outer retina and RP, so thereby protecting against involution and geographic control. That can also be a reason why these eyes maintain good vision. So one nice IOBS article by Adrian and group, they tried to assess the vascular component. So this is the pre-treatment when you see that the homogeneous tissue just underlying the elevated RP is the vascular component. Now it's always initially it's just a serous with vascularization. But when you undergo multiple treatment, you can see that now the formation of the multiple lamellae, above which still the active neovascular components there, and below at the area of the white arrow, you see what you see is the precordial cleft. So the sequential layering of all these bands is because of the treatment response and healing response of the neovascular tissue, and mainly comprised of fibrocellular elements. This is the OCT showing the neovascular component. The yellow, what you see is the yellow area is the neovascular component. In the initial phase, the pre-treatment, they saw it was rising from one corner, one edge, and as the lamellae started forming, multiple lamellae started forming, it became more or less uniform in a multi-layered pattern. So the neovascular tissue became more and more uniform, whereas it was at one edge when it started. So one more case from their series. Again, you can see the initially starting from one edge, and as the disease progresses and the lamellae form, it becomes more and more uniform all around the lesion. Again, this one more case. Again, you can see that what started as a small vascular element keeps on increasing in vascularity as the disease progresses and multiple lamellae are formed. And you can see what was initially a serous PED getting that multiple lamellar pattern in 3D OCT also. So again, this is showing two cases from their series. OCT showing the appearance of lamellae and the precordial cleft as the disease progresses. So precordial clefts, or what is, as I again told you, the hyperreflective spaces, and some of the authors have mentioned that this can be a cause for poor visual prognosis in these patients. And these are seen in a higher intensity in type 3 CNVM, and also not compared to the other subtypes, the RAP lesions. So again, the reason these form is the contractile forces causing formation of outwardly bored hyperreflective cavity beneath the fusiform, and partly it's because of the fluid, exudative fluid also. So sometimes what you see is in the treatment response to injections, this precordial cleft can also disappear in some of the patients. So the eyes with the precordial clefts are more prone to get large RP tears, significant subretinal hemorrhage, and also more extensive fibrosis, submacular fibrosis. So multiple studies have shown that most of these patients have a poor progress, but some of the studies also shown that they are better. But this article from Zhong et al., they showed that visual prognosis was poor, especially the precordial cleft started within 6 months of therapy. And this is one of the findings in this article. And in this article also from Rio Mukai et al., here also they showed that almost 23% of the eyes with the CNVM had precordial cleft, and so this resulted in significant risk of RP tear as well as hemorrhage. In this study by Kim et al. In type 3 neovascularization, again they showed that the risk of getting RP tears and subretinal hemorrhage was quite high, almost 21% for RP tear and almost 27% for hemorrhage. So the hypothesis that the RP tear develops due to contractile forces because of the sub-RP tissue which contracts, and also they showed that the edge of the PED can, these tissues can pull on the edge of the PED, causing a massive sub-neurosensory retinal hemorrhage also. So this is one of the hypotheses which they assumed which can be reason for extensive hemorrhage in these patients. So again, treat and response also, people feel that eyes with precordial clefts may not respond as well as other eyes where there is no precordial cleft present. And this has been shown in multiple studies. In some eyes, like you see here, you can see the response after treatment has been quite good, and the cleft has disappeared. So that's why they assume that it's partly exudative also. So that's why the response to treatment, it can disappear also. And there's one more eye showing the resolution of precoronal cleft following therapy. But unfortunately, you can see that the large RP tear in the bottom OCT. You can see the left side part of
1 minute remaining.
Large RP tear. So again, multiple studies have shown that this may be like when you're seeing a case like us, this in our case, so you can probably assume that these eyes may not respond as well as to anti-VEGF therapy like other eyes. So you may have to a little bit prognosticate and explain to the patients that we may need multiple injections or sometimes changing injections also, like in that case. So lateral elongation of PCV, the second, this thing is nothing special, but it's just it was mainly published by Girdhar's group. They showed that in treatment naive eyes, especially in fellow eyes where you see the alphaloi of active PCV, we may be able to pick up these flat, shallow PEDs with the bottom reflectivity. So these can initially be asymptomatic, but as the years advance or months advance, it can go on to produce active SRF as well as CME and bleeding also. So they showed that you need an average lateral expansion or extension of the lesion to become from asymptomatic to symptomatic was approximately 461 microns plus mean of 461 plus or minus 150 microns. So this was what they hypothesized, that when a PCV shallow PED extends beyond 450 or 500, the risk of becoming asymptomatic from asymptomatic to asymptomatic becomes higher. So to conclude, all these new biomarkers add more knowledge to our pathogenesis as well as help us to prognosticate. And as a routine, when you see cases, treat cases in our clinics, rather than just superficially seeing images, we can tend to see a little bit, scrutinize all these images. We can pick up all these biomarkers as well as prognosticate. We can also pick up new biomarkers which we can publish from now. Thank you.
Thank you. Thank you very much, Dr. Sharman. So we can say that a multi-layered PAD has a protective effect and better visual acuity, right?
Yeah. It's mainly a treatment response where the part healed and all these lesions form multiple lamellae over a course of treatment.
I had a quick question, Sarvanan sir. Which is of more concern, whether the height of the fibrovascular PED or the lateral elongation of the fibrovascular PED?
No, the fibrovascular PED is seen in more in type 1 and type 3. The lateral elongation is mainly disease what you see in PCV. So these are all totally different entities. PCV, asymptomatic to symptomatic, what they show was you need to have a minimum of, assume the study, the series of patients. Giridhar sir, if there you can add also. When they saw that minimum average extension of 460 micron from the baseline led to symptomatic lesions like SRF and bleeding and all those things.
Thank you.
Thank you.
Just quick question.
No, we have two more speakers, Srinivas. We can take it at the end.
Okay. Sure.
We have Dr. Muralidhar, who's going to be talking on OCT and OCTA in PCV. On to you, Dr. Muralidhar. Are you there?
Yeah, he's
there. Yes.
Yes,
Chitra. Thank you, Chitra and Srinivas, for asking me to be part of this wonderful symposium. And we have seen ARC being very dynamic, and doing so many webinars almost every week. I am seeing the mail that they are doing a webinar, and thank you for asking me to be part of this. After listening to all the young brigade coming out with a lot of these newer entities, newer names, which are so difficult to remember also and understand. What I talk may look a little archaic, but I'm just going to be focusing on the basic, changes of OCT and OCTA in PCV, not going into the real depth because of the time factor. Clinical features are almost always suggestive of PCV in a given patient. We all know that ICGA is the gold standard. Almost all the studies like Everest, Planet study, etc., defined the ICG characteristics of PCV very well. So I'm not going into the detail of that. So when we have a well-defined modality for diagnosing, PCV, ICGA, why are we now bothering about looking at another modality. The problem is ICGA is not widely available. OCT is definitely much more widely available, much more accessible. OCTA is also coming up in many more places than before. ICGA is an invasive procedure, whereas OCT and OCTA are non-invasive. So these are the reasons why there is a resurgence in the interest to use OCT and OCTA for diagnosing PCV, instead of using ICGA. Also, we know that in the last 6 months to 1 year, there has been non-availability of dye for doing PDT. And PDT was one treatment modality which required ICGA in order to measure the lesion and give the treatment. And since the PDT is not available right now to all of us, ICGA seems to have lost its importance in making a diagnosis of PCV. So OCT features in PCV, distinct features have been described in the literature. This helps in diagnosing the PCV even without ICGA. And of course, OCT also helps in monitoring the response to activity and giving us the decision to non-responder and change the anti-VEGF agent if required. Now, this is a 70-year-old lady who has come with a recent decrease in vision. Vision is still 6/9. You see a lot of changes temporal to the fovea. Fovea itself is not so much affected. That's the reason for good vision. And when we do the OCT in this eye, we see two classic features suggestive of PCV. One is a thumb-like PED with a hyperreflective material here. The other one is a double layer sign. Now, these are some of the important OCT features of PCV. Thumb-like PED was defined by Jimmy Chung as inverted V configuration, having a sharp vertical incline of more than 70 degrees on at least one side. The base to width ratio should be more than 1. And all the studies have shown that these thumb-like PEDs or narrow peak PEDs correlate very well with polypoidal lesions seen on ICG. Double layer sign is again another important pointer to the presence of PCV. Here we see two highly reflective lines, the inner layer being the RPE and the outer reflective layer being the Brooks membrane and the choriocapillaris complex. It is seen to be present in about 85 to 95% of eyes with PCV. Having said that, I must also say that it is seen in many other conditions, notably like CSCR also. And these are supposed to represent the areas of BVN, and if they are associated with neurosensory detachment, it may indicate an active PCV. So this slide shows this patient is a 70-year-old gentleman who came with a defective vision since 1 month. Vision is 6/24. OCT here shows the double layer sign and the thumb-like polyp, but it also shows another feature of PED that we see in PCV, that is a notched PED. So notched PED is again another sign of PCV, resembling an M if it is large. It's a or multilobular PED. And this is a 60-year-old lady who has large serous detachment. In some of the sections, you can see that there is this M-shaped serosanglia, the PED that is seen. So again, this OCT here in a 67-year-old lady with a vision of 6/60, 1 year, one month duration. This shows almost all the features that we see in a PCV. There is a notched PED here, thumb-like polyp, and double layer sign. So these are some of the important PCV characteristics of this one. In addition to all these three, one more characteristic that is seen in this eye is a pachychoroid. Now, what is pachychoroid? Pachychoroid is a condition where there is a thick choroid for age, especially in the subfoveal region, choroidal thickness of more than 300 microns that is seen on EDI OCT. This is due to dilated Haller's vessel. These dilated vessels compress the overlying choriocapillaries and almost obliterate them or attenuate them. And pachychoroid itself is a spectrum of diseases, and PCV is thought to be one of the diseases in the spectrum of pachychoroid, the other being pachychoroid pigment epitheliopathy, CSCR, and pachychoroid neovasculopathy. The other lesion that has been described as an important pointer of PCV in Jimmy Cheng's article is sub-RPE ring-like lesion. This is what they have shown in their article, and we could find one patient in whom we could find a sub-RPE ring-like lesion here, in this eye that had PCV. to be frank with you, I have not really looked at this entity much in our own clinical experience. This is a recently published article by Jimmy Cheng, where consensus nomenclature and non-ICGA diagnostic criteria were reported from a working group, and they listed 9 non-ICGA features, out of which 7 were on the OCT and 2 are on the clinical fundus photograph. And all the features that I mentioned, like sharp peak CED, sub-RP ring-like lesions, multilobular PED, double aroid sign, and a pachychoroid, all find a mention in this article. These are all pointers to making a non-ICGA diagnosis of PCV in a given patient. It also gave us new terms. So instead of calling them polyps, these authors suggested that we call them as polypoidal lesions. And instead of calling it as a branching vascular network, they suggested that we call it as branching neovascular network. Of course,
1 minute remaining.
Time will only tell us whether these terms will be accepted by all the people. So OCT also guides the treatment. Response to treatment can be judged by decrease in the SRF, IRF, and the PED height, and conversely, increase in the PED and appearance of SRF would mean reactivation or a non-response. A few words about OCTA. OCTA shows us more the branching vascular network much better than the polyps, as compared to ICGA. But however, on-fast imaging can definitely show polyps very well, and reduction in the branching vascular network is observed, after treatment, and this can monitor the progression or regression of the disease. Here is on-fast OCT showing the polyps that are seen corresponding to the ICGA, and the branching vascular network is also seen very well on OCTA. This is a patient who shows reduction in the branching vascular network seen on OCTA, and it has reduced following anti-VEGF therapy. So can OCT and OCTA replace ICGA? A few words on this. We did a retrospective study of 80 eyes, compared OCT and ICGA for picking up PCV. We could find that OCT showed 90% sensitivity and 92% specificity for picking up PCV in our patients, who also had ICGA for making the diagnosis. So today OCT can be used in most of the instances to diagnose. Other studies have also shown that the sensitivities and the specificity varies from 94 almost to 90 to 80 to 90% in picking up PCV lesions based on OCT alone. So this is a systematic review and meta-analysis of OCT angiography in the diagnosis of polypoidal choroidal vasculopathy, recently published in Journal of Ophthalmology by Wang et al. They also showed that OCTA revealed a high diagnostic detection rate of polyps and BVNs by OCTA in PCV, and the detection of course, BVNs was much higher than that of the polyps. That's what I also alluded to earlier. So in conclusion, OCT and OCTA in PCV are important for workup and making the diagnosis. Characteristic features are present on OCT that can help us to diagnose PCV without the need for ICGA. It's invaluable for monitoring the response to therapy. Being non-invasive, easily accessible, and cost-effective, ultimately, with passage of time, this might replace ICGA. With more refinements in the imaging technology, we may ultimately replace ICGA with OCT on OCTA in managing our PCV patients. Thank you very much for the patient listening, and thanks for this opportunity.
Thank you, sir.
Thank you very much, Dr. Muralidhar. That was an amazing talk, and all my questions got answered, so I don't have questions.
One question, Murli sir. We all know polyps usually doesn't have a lumen, but this has a lumen. Still, there is a controversy in the Western literature where they still do not want to call it as a polypoidal, and they want to call it as a type 1 aneurysmal dilatation. What is your take on this?
Well, see, it's all semantics. It comes to semantics. It all depends on who is propounding what. I personally feel that because ICG does show polyps very well, there is some lumen there. It's not a fleshy lesion. So I feel instead of calling them polyps, they should be called as polypoidal lesions or aneurysmal dilatations. They are not actually polyps, which, if you take polyps in, let's say, GI tract or colon or, stomach or anywhere else, they are all fleshy structures which do not have a cavity, which do not have a lumen. Whereas the polyps that we see in the PCV, or they do have a lumen. So I think over a period of time, we probably will have to get, get used to the newer terminologies and start using them.
Thank you very much, Dr. Murlidhar. We shall now go on to our last speaker, Dr. Shaurya Vardhan, who is a consultant Vitreous Retina Services from RP Center. Is he there with us?
Yes, ma'am.
Yeah, so look forward to your talk.
Okay, are my slides visible?
Yes, yes, yeah, yes.
Yes, sure.
Okay, fine. So at the outset, I'd like to thank Chitra ma'am and AIOS for giving me the opportunity. And as everyone else has also talked about terminologies, I'll be talking about a little bit more. So I'll be talking about C-RORA and I-RORA and focal choroidal excavation. So OCT has gone through the revolutions, and definitely since we can see many more structures than we could before, we are now having a lot of terminologies, and it's at times difficult to keep up. So the first two terminologies are basically related to AMD. So they are related to both dry and wet. I'll be discussing how they are related. So first, the dry AMD has always been, sort of the definition goes by geographic atrophy. So it was around an oval area of hyperpigmentation or depigmentation, visible underlying choroidal vessels, and they gave a definitive size to it, and it was classified on a color fundus photo. Recently, they have been monitored with the help of FAST, and some of the studies have actually used geographic atrophy even for wet AMD. So it's a loose term. So what now has become is that we have got a classification of atrophy. So there were people who have all the panel retina specialists and other retinologists, histologists came together, and then they gave a consensus terminology defining atrophy specifically in AMD. So before, it was being seen on a color fundus photo and a FAF. Now it is being seen on an OCT, because the OCT can give a layered evolution of these changes of retina, and which was not possible otherwise. So there are series of 6 meetings that have been done till date, and the first meeting was done to discuss all the modalities that we have at present, which can assess the atrophy, and they all the panelists, all the experts, they debated about the advantages and disadvantages, and they came to a conclusion that for non-neovascular AMD or dry AMD, a colored fundus photo, FAF, infrared image, and an OCT should be done at the baseline and the final outcome point. Whereas for a new vascular AMD, because of the new vascular membrane, FA is also recommended in addition to these at the baseline and at selected follow-ups. With report 3, they came up with 4 terms, out of which we'll be discussing 2. One was complete RP in outer retinal atrophy and incomplete RP in outer retinal atrophy. So let's see how they fit into the AMD spectrum. So the atrophy in AMD is actually divided into dry or wet. It can be in either. So typically it was described in dry AMD and what we knew as geographic atrophy. So what we have as complete RP in outer retinal atrophy is a broader term for geographic atrophy. It can be present in wet form as well as in dry form, but geographic atrophy has been retained specifically for dry AMD. And nascent geographic atrophy is the term which will be given to incomplete RPE in outer retinal atrophy. So what exactly is complete RPE in outer retinal atrophy? Well, previous studies have actually mentioned all of these. They have just given a particular dimension to all of them, and they have called it a particular sign. So it's a region of hypertransmission of at least 250 millimeters in diameter, as you can see by the images, and a corresponding zone of attenuation or disruption of RP, and an overlying photoreceptor degradation, and it should be in absence of a RP or a RP scrolled RP or a sign of RP tear. So what are signs of photoreceptor degeneration? Well, it has been discussed earlier that there is thinning of the outer nuclear layer, loss of IZ, EZ, and ELM. So it's already been discussed. Then moving on to what is incomplete RP and outer retinal atrophy. So anything which did not fall in the category of CRORA came into IRORA. So if there is increased signal transmission and a corresponding attenuation of RP with overlying photoreceptor degeneration, but not conforming to the size, then it would be termed as IRORA. And they would be thought as a precursor preceding CRORA. So if you can see over here that you can see large drusen's and pigmentary changes in a clinical photo. And if you see on the OCT, you are seeing the subsidence or sinking of the inner nuclear layer and the outer plexiform layer. And there's loss of EZ, IZ, and the ELM, and there is increased signal transmission with RP attenuation. Another case, there was same finding, except that you can see a wedge-shaped defect, hyporeflective wedge-shaped defect, which is there in the Henle's layer. It's another sign of IRORA. So this is a case of IRORA going into a CRORA. So if you can see at baseline, there's a large drusen and few pigmentary changes, and then you can see on the corresponding OCT that there was a drusen, and the drusen has still has a hypertransmission, and there's ELM disruption as well. But the RP is fine, so it does not fall in the category of IRORA. And at 6 months, this changes and the drusen collapses, and then you have increased transmission, you have signs of out of photoreceptor damage as well as attenuation, and then it becomes an IRORA. At 18 months, the IRORA has established itself, but then it is still not meeting the criteria of a CRORA. So at 30 months, you can see that there is complete loss of the RPE, and then it starts falling into the category of CRORA, and then it becomes established more so at 48 months. So what are the implications of these findings? Well, as it has been proposed earlier, the nascent geographic atrophy goes into geographic atrophy. It's similar over here as well, that IRORA then progresses on to CRORA. So basically now we have some sort of a parameter that we can check on an OCT, and then we can plan interventions so that we can stop it at the stage of IRORA, and probably even try to find a time point at which we can reverse the changes and not go into irreversible changes. So basically, it is just a way of finding a reproducible measure which can be used in trials so that we can have interventions which can reverse the process if possible. Moving on to the second terminology is focal choroidal excavation. Well, it was described first by Jean-Paul et al. In 2006, and it is nothing but a concavity in choroid, which is mostly macular and rarely extramacular. Its presence mostly in the 4th and 5th decades is reported mostly in Asians and associated with refractive error like
So 1 minute remaining.
So FC can be classified as conforming type, in which the retinal layers actually conform to the cavity, and non-conforming types where it does not conform to the cavity and there's a hyporeflective space between the RP and the photoreceptors, or as congenital or primary, which are present since birth probably, and are just incidental findings on an examination, and acquired or secondary types in which their primary pathology is something else, which actually leads to a focal choroidal excavation. So I'll just be discussing few cases. So this is one patient who came just for a eye checkup, for a refractive checkup, and we found a pigmented lesion just above the disc, and on OCT you can see that there is a cavity and there is the retinal layers are conforming to the cavity. So it is probably a conforming focal choroidal excavation, which is congenital because he did not have any other associated pathology. So going on to acquired pathology. So this is a case that we published, choroidal osteoma, and we can see that as the evolution of osteoma goes on, there is deossification of the osteoma that might lead to cavities that are made in the choroid, and this is a form of an acquired sort of a non-conforming choroidal focal choroidal excavation. Then it can also be associated with inflammatory conditions like punctate inner choroidopathy. So you can see that these punctate lesions that are there at the macula, and on OCT, if you can see, there is a small excavation, and it also happened to house a CNV, which is a known association. It can also be associated with dystrophies. So in such a case, this case was of a Stargardt disease, and you can see that there is a excavation in the choroid and the layers of the retina conform to it. So it is a conforming focal choroidal excavation, which is seen in a Stargardt disease, probably due to degeneration. So implications, well, if it is a congenital, mostly seen in myopes, not associated with any chorioretinal disease, it's supposed to be stationary and it's an incidental finding and should not be vision threatening. In acquired cases associated with chorioretinal diseases, it may progress to complications and lead to vision loss like CNV. And also cases of pachychoroid CSC have shown to be associated with focal choroidal excavation, and thus if stationary lesions, I would not mind following it up and probably just seeing an OCT through that lesion, maybe every time the patient visits, to see whether there is any progression in such cases. Thank you.
Thank you very much, Doctor. So much of information, and each talk one to beat the other. Srinivas, do you have any question to ask?
No, I think he has covered it really well and deciphered it very nicely, line by line. I think it was very clear, nothing more to add. I think we can have, the time is up and we can have some final comments from two of our panelists, Dr. Anand sir and Dr. Unni sir, please.
Yeah, I mean, specific to this talk, I mean, excellent, very elaborate talk. Focal choroidal excavation, we've seen in a host of pathology, touched upon a good number. It's part of the pachychoroid spectrum and acceptable aspect. I think the one thing that we need to just understand is that when you see that cavity there, a lot of you should not jump the gun and think it's fluid that needs to be treated with repetitive anti-VEGF therapy. So it's part of the pachychoroid spectrum. That's the only aside. But otherwise, I think you covered those things well.
Yes.
Last comments from Unni sir, please.
And basically, it was a great talk. I just want to just make a small stress. This is just a small thing for the general ophthalmologists. The term that is introduced, CRORA, is the umbrella term. Geographic atrophy is a subset of CRORA. You can define CRORA in the presence of elevations of the RP, that is PED and CNBMs. So geographic atrophy is when basically when the RP is flat. So it's a subset of CRORA. Anyway, it was the whole seminar was a very great teaching experience, and it was a pleasure to attend and hear everybody, including Anand with his insightful comments. Srinivas, you did a great job moderating. Dr. Giridhar, Dr. Muralidhar, all stalwarts and seniors. Great to see Dr. Sharon also.
That's absolutely wonderful session. I mean, the energy levels are amazing. Dr. Chitra leading from the front. Srinivas always was an energy pack. Thank you very much. Great thanks to all the speakers. I think everybody did an excellent job. There's a huge amount to be learned and a lot of insightful interactions and comments from Unni and everybody else here on the panel. Thank you very much.
I think I'll give my conclusion remarks, and I would just like to reiterate what Dr. Unni and Dr. Anand said, that there has been truly great contributions from the expert panel and extremely capable speakers who left no stone unturned. And I think it's just one more milestone that ARC has seen today to leave behind a much remembered webinar. Our special thanks to one and all of you. My thanks to my co-moderator, the young hero, Dr. Srinivas, and my strong ARC team. Thanks to AIOS admin, Mr. Kripal, with his team who are always there for us. Sai and Manjula from Numerotech for our great strength. And of course, Anand Sethi, whom all of you would have interacted with, the meticulous way in which he forwards the link and keeps tab on how the timing of the webinar goes on. Our most special thanks to Entoad. They have been our major sponsors and have been constantly there supporting and backing any number of webinars which I try to conduct. And finally, I think it has to be said again and again that if we keep trying to do better, it's the amount of interest which are shown by attendees and the number of them watching. And believe me, I keep getting to hear and see that how these YouTubes and websites are visited over months. So believe me, dear speakers and expert panel, that all these talks will be heard by many, many more over the months to come. And I think this we leave behind a truly great library of knowledge. Thank you very much, all of you.
Thank you, everyone. Thank you.